Okay. So we chose to do valerian. I'm McKenna, and we also have Madeline Hill and Dakota Cummings. So the history of valerian. Valerian and its many uses have slowly evolved over time. It has been used medicinally since at least the times of early Rome and Greece. And its first therapeutic. What was that?
You can take your mask off if you want, so you can talk a little.
And its first therapeutic use was for insomnia. In the 16th century, it changed a little bit. It was to treat nervousness, headaches, and heart palpitations. And then by the 19th century, the plant was considered a stimulant that inversely caused the same complaints that it was thought to treat. So most people didn't really consider it an herb or medicinal at all. And then during World War II, valerian was used to relieve the stress of air raids. And then, is it a specialty supplement or an herbal product? It is considered an herb. It is commonly sold as a dietary supplement in the United States. It is therefore not regulated. It is more regulated as a food and not a drug. So you can kind of get around some of those guidelines. So therefore, the pre-market evaluation has approved by the FDA are not required since claims are not made for specific treatments or disease prevention. And then since dietary supplements are not always tested for manufacturing consistency, the composition can change greatly depending on the company and who manufactures it. And then knowledge about valerian is limited due to the fact that they have not done a lot of research. And usually the sample sizes that have been provided are pretty small. And so therefore we don't know a whole lot about its effects on various conditions.
Oops, sorry. My bad.
Good job, Courtney.
I know. Next time I'll share the screen so it's a little bit easier. I just want that next slide to go there. Okay, sorry, go ahead.
Okay, so conventional medical therapies. So valerian is promoted for insomnia, anxiety, depression, premenstrual syndrome, menopause symptoms, and headaches. So when they use the plant, they use the roots and the underground stems, which are also called the rhizomes. So that's what they use for the medicinal purposes. It's a common ingredient in products that are promoted as mild sedatives and sleep aids. It increases the levels of GABA in the brain and in the brain, contributing to the calming effect in the body. Common prescription drugs for anxiety, such as alprazolam, Xanax, and diazepam, Valium, also increase GABA levels. So it kind of interacts with those. Next slide, please. So the adverse effects, most common are headaches, dizziness, pruritus, and GI disturbances. But when they were testing with the placebos, they also found that some of the placebos had the same effects. So some of these, they're not 100% certain. A lot of looking up, when I was looking up the drug, a lot of the things, there wasn't a lot of research done. There hasn't been a lot of research done on it, so a lot of it I'm not 100% certain on. Side effects can also include mental dullness, excitability, uneasiness, heart disturbances, and even insomnia in some people. A few people feel drowsy in the morning after taking valerian, especially at higher doses. Some people experience dry mouth or vivid dreams. Because it is possible, but yeah, then again, not proven, valerian might have a sleep-inducing effect, so it shouldn't be taken with alcohol or sedatives. That would include opioids. The root seems to work best after taking it regularly for 2 or more weeks. So you shouldn't take valerian longer than a month without talking to your doctor. Next slide. So it was a perennial plant that is native to Europe and Asia, but it's been naturalized in North America, although I found that it's an invasive species in some states, so it's banned in Connecticut, which is interesting. It provides a white, purple, or pink flower in the summer, and the flower smells sweet, but when you get the oils from it, it has like a very distinct odor, and some describe it as dirty socks or stinky cheese. And then again, yeah, the roots and the rhizome are the most common parts of the plants that are used. Next slide. Oh, and I forgot to say I saw that it attracts cats like catnip, so that's interesting.
All right, so the amount of valerian root contained in each capsule varies widely. When it's taken for insomnia, it's recommended that you take 300 to 600 milligrams of the root and right before bedtime because it does cause that drowsy effect. It's also common to come in a tea form, 2 to 3 grams of the root in 1 cup of hot water, just to help with the calming effect and to relax you. When taken for anxiety, they recommend lower doses, 120 to 200 milligrams, 3 times daily, just because it does cause a drowsy effect and they don't want that for anxiety, just to calm the effects. Next slide. And then the powdered valerian root is available in tablet form. You can get it online or in drugstores. They don't know if there's like any adverse effects to overdose because there's no standard dose for the root, but they have documented before that if you take 900 milligrams or more, that it can increase sleepiness and cause some sort of like hangover effect the next morning. Next slide. So for our little learning activity for the class, we just wanted to have this mnemonic for you guys to easily remember. So valerian causes you to be very sleepy. Alcohol is bad to mix with it because of the CNS depression. Little research is done on it. It's a European root. It smells, so it's really smelly. Increases the GABA levels in the brain. And it's used for anxiety, and you don't want to take more than 900 milligrams or it can cause a hangover. And then our next slide is just our references.
This would be a great slide to get a test question off of. Just saying. I'm going to say that right now. Okay, next slide. References. Okay. Perfect, guys. Okay. I didn't necessarily want to do that. Whoa. Back that off, right? Okay. How do I get that down now? Okay, anyway, let's see.
The little like speaker on your cheek looks like a Snapchat filter.
I hate this light. I need to.
Yeah. Where'd you go?
They say they miss you, Steph, if you can't hear them. Miss you in class. They'll miss you. Oh, got it. Okay. Affecting me. Holy moly. Okay.
I think you're doing great.
Thanks. I appreciate it. All right. Sorry about that, guys. I don't know. I really have no excuses, but now where's my screen share? Where did it go?
Yeah, we'll never know. I know. Scroll up. I'm curious what Stephanie said. You won't show Bill it?
I know it won't. Debbie, I think you have control now that I left. Can you maybe switch it over to me?
Sure, I have control. How do I do that?
I think so.
My goodness, I didn't realize I had such power. Let me.
I decided to log out all of a sudden, and I didn't mean to.
Okay. Do you want me to share the application window? I don't have your. Okay, hang on here. Your entire screen share.
Yeah, I passed. Did you?
Hmm.
Just up in the options up top, can you?
It's coffee. I know it is coffee, but it smells like something else too.
I'm trying to share the screen. It's not letting me.
Yeah, like some kind of. It's really like a.
Let's try that.
If you tell me to do something, I'll do it.
Okay. That work?
Nope.
Sharing.
Hold on. I think I got it.
Emergency coffee.
Oh yeah, we got it.
Okay. Perfect.
Okay. Sorry about that.
No, you're fine.
Okay. Megan, Victoria, and Mark. You ready? Are y'all ready?
Let's do it.
Okay.
I love your shoes.
Okay. I think that'll show you. All right. What do you want me to do? Can I move it? You want me to move it? I can do the slide.
Okay.
You can just tell me when. I'll hide.
Well, we're doing St. John's Wort.
So with St. John's Wort, just a little background. The history with this is that it was first administered by a Roman military doctor. Not going to try to say his name. No, I'm not. So as early as the first century AD, it was interestingly, it was mainly used for like magic potions and stuff during the Middle Ages, and it was also used to protect humans and animals from witches, demons, and like evil diseases and stuff. So with the name, it comes from John the Baptist, and it's because the flower, it blooms around the time of the feast of St. John the Baptist in the late June, so that's why it's named that. But more recently, it's not really a cure for like witches and demons. It's more so for like mental disorders. It helps treat like depression, anxiety, ADHD, OCD, even nerve pain. And also it can be used to treat like malaria, sleep disorders, wounds, menopausal symptoms, muscle pain, and bruises. So just a little bit on the effectiveness of St. John's Wort. So it's like I just said earlier, it's an herb that is typically used for depression. It's typically more effective than any placebos that were tested. And it's shown to be just as effective as standard antidepressant meds for mild to moderate depression. But it's uncertain if it's really effective for severe depression for like longer than 12 weeks. And it's been tested more, and it's been shown to not be as helpful as like other conventional therapies that we have with like IBS, social anxiety disorder, chronic hepatitis C infections. And there's just not enough evidence really to support how helpful it is for improving like memory, really reducing anxiety, ADHD, and even like seasonal affective disorder.
Okay, so the active substance is found in the flowering part of the plant and the leaves, and it's called hyperforin.
Okay, so it doesn't have to do anything with grapefruits, but it's kind of like a grapefruit because it has a lot of medication interactions.
So there you go.
The medications, it can like interact with our antidepressants, aprenolol, oral contraceptives, digoxin, cyclosporin, HIV drugs, some cancer medications, and warfarin. Some herbs that it can interact with are potentially like many of them, especially the ones that 5-HTP, L-triprophan, and let's say MD. So basically, it reduces the effectiveness of medication. So it's important to talk to your doctor before taking it because it can decrease the effectiveness of other medications that you're taking. Yeah. I told my mom that. She just put me on that when I was little. I was going through puberty and she's like, take that for your mood. So scientific support of health claims. So the main thing that people take this for is depression because research has shown that that there is a therapeutic benefit in treating mild to moderate depression by taking it, and some studies have shown that it is as effective as antidepressants. For the menopausal symptoms, it is used in a combination with black cohosh extract to help reduce symptoms like hot flashes. And we were reading another study showed that sometimes the efficacy of it is not certain because people can put extra things in supplements since it's not regulated by the FDA.
All right. The recommended dose for St. John's wort is 300 to 1200 milligrams per day. And because of all the side effects and everything, that's definitely something that you want to be cautious of and be careful with if you're taking other medications and don't want to go over that dosage. And a bottle of St. John's wort, I mean, you can get it anywhere. You can buy it at Walgreens, any pharmacy. You can get it on Amazon. You can grow it in your own backyard if you wanted. But if you wanted to buy a bottle, it's about $8, and it'll last you probably a couple months. Next slide, please. All right, for our learning activity, we're going to play a little game. It's called Wart or Wart. So we're going to have a question, and you guys just shout it out if you think it's wart or wart.
Sorry, my head's
All right. So a non-cancerous skin growth caused by AV.
A or O?
It's a wart. All right, next question. Supplement used to treat certain mental disorders like depression, anxiety, ADHD, and OCD.
Oh.
Oh. All right, can lead to serotonin syndrome when taken with antidepressants. Warts. And cured by rubbing a potato on it, then burying the potato.
What?
Make sure you bury that potato or it's not gonna work.
Yeah, you have to bury the potato or it won't work. So that's an old wives' tale. They used to believe that if you rubbed a potato on a wart and then you buried the potato, when that potato got all dried up, then the wart would dry up as well. Fun fact. All right, last one. Shown effective in treating symptoms of menopause like hot flashes and irritability.
Oh.
You guys are so smart. All right. That's it for wart or wart. And those are our references.
Fantastic. All right. Good job, guys. All right. Let's take I don't know, 3 to 5 minute, stand up, jump up and down, get the blood going. Who can tell me what we are? Who knows, just based on St. John's wort and valerian, what we might be talking about today?
Depression.
Mental.
Yeah, I was just gonna say mental behavioral.
Behavioral.
Stimulants.
CNS stimulants. Yeah. See, you guys all got it. It's as if. We'll start with 14.
Depression and anxiety and too. You're in Those were your review stuff.
Want to do lunges in the hall?
You started it.
Trying to turn up the Amy?
Oh, Megan. Okay, good question. Any side effects or adverse effects? I think one big takeaway with St. John's wort is that it interacts with pretty much everything. Any type of medication, any type of anything you're taking, yes, tons and tons and tons of interactions with St. John's wort.
Yeah, like almost like anything. The biggest ones are like any of your antidepressants, because there's a thing called serotonin syndrome, and I mean it's really bad. It's an emergency situation, so
Yeah. So I
all
guess
your
like,
vitals pretty much drop.
yeah, and I guess like it decreases the effectiveness of a lot of drugs, but with I guess the serotonin is like the only one to catch all where like it can increases the serotonin, like Mark said, and can cause serotonin syndrome. So
Perfect. Do you guys any other questions for either group? Fantastic. Okay. I'm just gonna pause the recording for just a hot minute. I forget to do that. Okay. So we are going to start with Unit 14, which is stimulants, which is Chapter 17. I know, all these double-digit numbers. Okay. So I posted so I have separate PowerPoints for Unit 14, Unit 15, Unit 16. In lecture, we're going to kind of skip around the PowerPoints a little bit, but hopefully it'll help make sense a little bit so we're not jumping around a lot. Let's start with stimulants, shall we? Okay. So here's your learning objectives. So when we talk about stimulants, you guys, I'm telling you right now, like I have this headache that may or may not turn into a migraine, so I'm trying to control it. So I already stumble over words. You guys already know that, but if it's worse today than normal, that's my excuse. Okay. So we're talking about CNS stimulants. So what part of the body are we going to be affecting? Central nervous system. Right. This is like the most simplified central nervous system I could find. Right? You got your brain, your spinal cord, and your nerves.
I like it.
That, I know we've talked over it before. You guys get it in other classes, so I think we're good on the central nervous system. Who feels like that right now? All of you guys.
Yeah, we should have done this at the beginning. I agree.
All right. So so CNS stimulants are used for a lot of different reasons. But there are only really 3 disorders for which they are FDA approved. Okay. So we have attention deficit hyperactivity disorder, or ADHD. Okay, and that's thought to be caused by dysregulation of the transmitters serotonin, norepinephrine, and dopamine. Okay, that's kind of what you're thinking. Narcolepsy, excessive daytime sleepiness from an abnormal pattern of REM sleep. And this is falling asleep during normal waking activities. Now, this is not like falling asleep in class because I'm incredibly boring. Okay, that's not what narcolepsy is. Anybody seen like videos of narcolepsy or they're like falling asleep in the middle of conversations. It can be dangerous because when we talk about the patterns of sleeping, the levels of sleeping, they can actually fall because like when we sleep, we have the muscle paralysis that happens in different stages of sleep. They can like fall into that stage of sleep and like fall. So this isn't just like I'm falling asleep in class or I'm really tired every day. this is like actually a really fantastic disorder. Yes.
Can I watch an educational video on
I can find one for you, yeah.
that?
I'll find one and post one for you. Let me make a note so I don't forget.
I mean, I can just YouTube it too, but.
Well, I'll find one. It's fantastic.
For the type A, I think it is, the narcolepsy, it can have cataplexy also, and that's really kind of funny to watch.
Yeah.
Yeah, because if they have a really strong emotion like anger or if they get scared or laughter brings that out a lot. They'll just start laughing and then they'll just go into the whole body.
And
It's
just
really
like
kind of funny.
fall asleep. Just with the
Well, they won't fall asleep. Usually it's just the whole body will get weak.
oh.
And then they come back on
Okay, yeah. Yeah, so narcolepsy and then apnea. Now, this is most apnea that's treated with the CNS stimulants are apnea from immature CNS development. So premature infants, those who work or have worked in NICU, you'll see some of these stimulants given to help them keep breathing. It's kind of an important thing to do. And then adults with COPD when they lose their respiratory drive. And we've already talked about one of those medications. Anyone remember? It's a xanthine.
Methylxanthine.
Anyone remember what drug that is?
Nope.
Okay, well, when we get to it, you'll be like, oh yeah, I remember that drug. Okay, so these are the only three that are FDA approved. Now, as we all know, there's always off-label uses for stuff, legal and non-legal. Okay, so major classifications of CNS stimulants. We have our amphetamine or amphetamine-like, our anoleptics, anorexiants, and then that's the mechanism of action of each one. So the amphetamines or amphetamine-like stimulate the cerebral cortex. Anoleptics act on the brainstem and medulla. Anorexiants stimulate the satiety center in the hypothalamic and limbic areas of the brain to suppress appetite. And then all of these that we're going to talk about have a really high level of abuse, dependency, and tolerance. So what can you probably guess with all of these? They're regulated, right? They're controlled substances. Yep. Some of them more than others. Okay, amphetamines. They stimulate release of the norepinephrine and dopamine from the brain of the sympathetic nervous system, right? We all remember that. And inhibit reuptake of the transmitters. So what does that do? Like in layman's terms, what does that say?
Serotonin in the.
Serotonin?
Or not epinephrine. Norepinephrine and dopamine in the brain.
Right. So it keeps more norepi and dopamine in the brain, right? It stimulates the release and it inhibits the reuptake. So we're going to have a lot more concentration of this stuff in the brain. Okay, it can cause some euphoria, increased alertness, which is kind of what we're wanting, right? And then these are available in prescription and also illegal forms. What about the side effects? What do you think some of these side effects are going to be? Weight loss?
Tachycardia.
Yeah.
Jittery, tremors, tachycardia, restlessness,
Hard time falling asleep.
Insomnia.
Insomnia. Funny, actually. I already have that.
Anything else? If it's stimulating the sympathetic nervous system, what else might you find? Heart palpitations, maybe. A little bit of bronchodilation, maybe. Anything else? There's a few other things. You don't have to try it to know the side effects. Okay, maybe some urinary retention, maybe some dry mouth, maybe a little bit of anticholinergic effects, because they kind of do the same thing, right? Ish. Dizziness, headaches, hypertension, blurred vision, maybe some confusion.
Paranoia.
We get a lot of it. Paranoia. Okay. So under amphetamines, we have two sections, the pure amphetamines and then amphetamine-like. So the pure amphetamines have a really, really high potential for abuse. This is dextroamphetamine or Adderall. Who's all heard of Adderall? Okay, never? I'll take your word for it. Okay, and then amphetamine-like. So they have a different structure than amphetamines, but they cause the same mechanism of action. They do the same thing. Okay, they have the same therapeutic effects, the same adverse effects, and it still has a really high potential for abuse, but not quite as much as amphetamines, if that makes any sense. And the amphetamine-likes, they're the first line treatment for ADHD. You see any questions in the future about that? This is where you find the answer. Amphetamine-like. So we're talking about Ritalin. There's a few others that we'll get to. I don't know if this is going to work. Hold on. Hold, please. Hold, please. We'll figure this out. Hold on, hold on.
Yeah.
I might ruin this.
Turns out the word Adderall thing on the is there free.
No. All right, hold on. Hold on, guys. Sorry. I really should be.
What did you start doing? Coffee. My secondary teacher said your class is open to stop talking. For 9 years that I'm not okay today. Is that really fast? This is I think it's 2001.
Corby, just FYI, it says that you're muted.
Sorry. Sorry, guys. I'm having a really hard time with this video. So with the methylphenidate, it's Ritalin. It's also known as Concerta, Methylene, Daytrana. Any of us have heard any of those brand names? Strattera? Oh, that's a good one. Okay, I think I know how we're gonna do this. Still not. Okay. I think let's, for the love, guys. Why isn't it sharing my screen now? There we go. Okay. I will figure that video out, and we'll either watch it a little bit later, or I will definitely post it. Okay. So, video about Adderall. Okay. Moving on. Amphetamines and amphetamine-like drugs. So, dextroamphetamine, Adderall, methylphenidate, Ritalin. Let's see. So, intended responses. So, what we're wanting to do, what kind of therapeutic responses that we want from this medication. So, we want to increase attention span, increase cognitive performance with memory and reading, decrease impulsiveness, hyperactivity, and restlessness,
We're gonna giggle all day.
increase motivation, euphoria, and mood lift. And so this paradoxical effect. So if you're thinking like, okay, CNS stimulants, we talked about what they do, what their side effects are. And if you think about like ADHD and kind of how kids and people with ADHD have, like, you think about it, why, I don't know, it seems kind of confusing that a stimulant would help impulsiveness and inability to concentrate and attention span, right? It kind of seems funny that it would help, but it's because of this paradoxical effect. What does paradoxical effect mean? Right, it works the opposite of what you think it would work, right? So what this does is in the brain, you have like these neurotransmitters that are just kind of everywhere, and these stimulants just kind of round them in and focus them. Does that make sense? So it takes all of this confusion and impulsiveness and stuff like that, and it just kind of focuses it all so they're able to concentrate, and it helps with that. Now, these drugs, so when you think about kids with ADHD, they usually struggle in school, right? Because they don't have the attention span. They are impulsive. They have these problems with memory and reading because they just can't stay in one spot very long. These drugs don't affect the level of their knowledge. I'm trying to explain this. Like, it doesn't
Make them smarter.
make them smarter. Right. It doesn't make them smarter.
It allows them to defy.
Yes, it allows them to focus so that they can learn easier and better. Does that make sense? So this doesn't, right, what Kim said, it doesn't make them smarter. It just helps kind of bring them in so that they are able to learn better.
You can actually apply.
Right, yeah, they can apply things and do that. Talked about a lot of the side effects: insomnia, irritability, increased heart rate, adverse effects. Okay, while we're talking about these I know in past medications and probably in future medications, we've put adverse effects and side effects kind of in one column. These medications are a little special where they all have side effects, but their adverse effects are really adverse effects, to the point where if you start getting these things, you need to stop medication, you need to switch medication. So we actually are in these units going to separate them out. Does that make sense? I don't want you guys to get confused, because I know before we've put them all together in one. But in this unit, in this week, we're going to separate them out, because you'll see one is, like, we'll get the serotonin syndrome, which is an adverse effect. And so they're really important to know kind of the difference in these units between side effects and adverse effects. Okay, so adverse effects with these: heart palpitations, tachycardia, dysrhythmias, paranoia. Mark, you talked about that. Abuse, psychosis. Whoa, that was delayed response. Okay, so here is your drug information for methylphenidate. Let's see. So we talked about the mechanism of action: stimulates the release of norepinephrine and dopamine, and it inhibits the reuptake of them as well. Okay, this one treats ADHD and narcolepsy. We talked about, this one isn't separated out, but I promise you. Side effects, adverse effects, contraindications: heart disease, hypertension. It'll cause hypertension, right? Make it worse. Parkinson's disease, hypersensitivity. If you're allergic to these types of drugs, don't take them. Tourette syndrome. It can actually make Tourette syndromes worse. Okay, it can make their symptoms worse. And it can actually, in some people, it has shown to people taking these have developed Tourette syndrome. Okay, drug interaction, pseudoephedrine. What kind of drug is that? Pseudoephedrine, what kind of drug is that?
That is antihistamine.
No, but we talked about it in the same unit. It is Sudafed, yes. Decongestant, but what type of drug is it? Like,
Where is that? I need a visual word. The one that makes meth out of.
yes, it is the one they make meth out of.
Nailed it. Done.
It's a sympathomimetic. Who said that? Okay, Moku, sorry I didn't hear you. Yes, sympathomimetic. Good job. Okay, so drug interactions. If this is a CNS stimulant, this Ritalin, we don't want to take more, right? Then it'll just add to it. So that includes caffeine, because caffeine is a CNS stimulant, which we will be talking about here in a minute. Okay, so if it causes insomnia and all that stuff, what's one of your nursing things that maybe you want to take in the morning? Don't take this thing at night, right? Also, you need to teach or tell your patients, right? Avoid food and other OTC meds with caffeine. What kind of food has caffeine in it?
Soda.
Chocolate, certain sodas, energy drinks. It does, yes. Chocolate has caffeine. Coffee, caffeinated coffee. What kind of OTCs have caffeine in them? Midol, Excedrin, migraine headache medicine. I do. Well, I've got my Tylenol and ibuprofen, which, by the way, I don't know if I mentioned when we were talking about opioids. There's studies coming out that say that if you take Tylenol and ibuprofen together, it can be equivalent to a Lortab. What? And that is one reason why you see people with simple surgeries as like appendicitis or gallstones or any type of laparoscopic surgery or even childbirth, they don't give, it's ibuprofen Tylenol. They don't give Lortab anymore. Part of it's because of those studies. The other part's because of the opioid epidemic that they're trying to not prescribe those.
It has like the same effect on the CNS as Lortab, but it doesn't have side effects like Lortab?
It has the same type of effects on the pain receptors. Yeah, so it helps control the pain pretty much. They're showing that it's pretty dang effective at controlling pain as Lortab is, but you don't have the opioid stuff with it. So interesting things to know. And then discontinuation needs to be tapered. Okay, so if people want to come off this medication, if they've been taking it for a long time, it needs to be tapered. Now, sometimes I have seen, and you definitely want to talk to the doctor about this to figure out the schedule, but a lot of kids that are on this will take it on days that they're going to school and then not take it during the weekends. And then I've seen schedules where they'll take them during the school year and then not take it during the summer. And that helps with the tolerance and the dependency, right? Because they're not taking it all the time on a regular basis. So, okay. Any questions about amphetamines and amphetamine-like medications? All right. Anorexiants. So these stimulate the hypothalamic and limbic regions. Most of these anorexiants are used to suppress appetite, and they don't have serious effects like amphetamines do. They should not be used for long-term weight loss. And actually, I mean, if you saw the FDA approval list, is it approved for weight loss? No, it's not approved for weight loss. Is it used for weight loss? Prescribed for weight loss? Yeah, but is it FDA approved? No, it's not. So it obviously needs to be under the care of a healthcare provider. Okay. Should not be given to children younger than 12 years of age. Where amphetamines can be, these anorexiants should not. Side effects, it's a stimulant, so you're going to get your nervousness, restlessness, irritability, insomnia, palpitations, hypertension, good stuff like that. All right, analeptics. So, anorexiants. Who knows like examples of anorexiants? Say it loud. Phentermine. Which was, Amy, what did you say? Fen-phen. Who's heard of fen-phen? Whose parents were on fen-phen? His grandparents were on fen-phen, I guess. So fen-phen used to be really popular, and it was phentermine with another drug. And it used to be really, really popular. And then they decided that, oh, maybe it's not super great for our health. People started having heart problems with it. So then they took it off the market. And they still do have phentermine, which is one of the phens by itself. So they do still have phentermine that is still used, not as widely, but it's still out there. Used for weight loss, but not FDA approved. Okay. Now analeptics. These are what are these used for? Who remembers? What was that, Kim?
I just read it.
Seizures.
Stimulate respiration. Fantastic. Okay. They affect the brainstem and the spinal cord. That's where your breathing is, right? At the very base of your brain. It's where your breathing control is. Okay. And so these are used to stimulate respirations. In which kind of people? COPDs and
Cystic fibrosis. I don't know.
no. Our little friends in the NICU. Preemie babies, right? Whose CNS The central nervous system isn't fully, completely developed, so they need a little bit of help remembering to breathe. Okay, and then one little subgroup of analeptics is the xanthines, or Mark, you said methylxanthine. Fantastic. Anything ringing a bell yet with what medication that might be? Uh-huh. Yes, theophylline. Good job, Mapu. You can say it however you want. I say it theophylline. Okay. So one of the big analeptics we're going to talk about is caffeine. Now, this is one drug in the stimulants that isn't necessarily controlled, right? We all don't need a prescription for caffeine. It'd probably be the most selling drug in the world if it required a prescription, right? So you need to know the mechanism of action for caffeine. It blocks adenosine from binding to receptors. Who remembers adenosine?
It's a heart med.
It's a heart med.
The one that
slows it down.
The one that stops it and then.
Yes. Yes. So if you give it fast, right? It's for SVT, right? Your patient comes in and SVT has a heart rate of 250. You want to slow that thing down. So we give it, right? Rapid push, super quick, resets the heart. So we have adenosine in our body already. And what this does is it blocks the adenosine from binding to the receptors. So our natural adenosine is not going to be working quite as well. It's going to keep us awake. It's not going to depress us. So effects are dose dependent. If you just have like half a cup of coffee, are you going to feel it as much as if you had 2 cups of coffee?
Or revolver, 6 shots of espresso.
Right. Yeah, so effects are dose dependent. Side effects. Once again, stimulants, nervousness, tremors, restlessness, palpitations, diuresis, because why? Caffeine is also a diuretic.
Also
Vasoconstrictor.
But coffee, I like it.
Oh, yeah. Coffee with peristalsis, yep. It can cause GI irritation. If anybody has had like a whole ton of maybe Coke on an empty stomach, has anybody felt like you're just kind of like, I kind of don't feel super great? It's irritating your GI system. Half-life is 5 to 6 hours. So if you guys want to sleep at night, don't drink caffeine 5 or 6 hours before you go to sleep. Within 5 or 6 hours before you go to sleep. And then extended half-life in the patients with liver damage, those taking contraceptives. Good to know. And then you want to be careful with people with pregnancy because effects on the fetus is unknown. So we don't know what caffeine does, especially in large amounts to pregnancy. So
That's why I have ADHD. Thanks, Mom. Why do oral agreements now?
Honestly, I don't know.
Yeah, the next question for the pin.
Okay.
Hang that up.
Hey, Corby.
Yeah.
Before we jump ahead, there's a couple of questions. And this goes back to stuff that we've already talked about. So the first one is Megan wanted to know, so as far as side effects and adverse effects, is that just pertaining to amphetamine or is that pertaining to every drug that we're going to learn about today?
It's going to pertain to pretty much every drug. That first slide, I forgot to switch over with the Ritalin. And I can do that. I'll separate them out and then repost it. But all the other ones should have them separated in their like med information boxes.
Okay, perfect. And then Megan also wanted to know if Adderall helps treat depression as well, because it mentions that in the video, or is it mainly just for like ADHD and narcolepsy?
It's mainly for ADHD and narcolepsy. we have other medications which we're going to talk about for antidepressants that are they have less side effects and they're not dependent, like they don't cause dependency.
Okay, so that should not be listed as something to treat depression, correct?
Right.
Okay. And then one more question on amphetamines, or sorry, not amphetamines, anorexiants. So obviously it's not FDA approved for weight loss, but that's the main reason that they're getting used. What other, like we learned about 3 disorders, what disorder is it used for? Because, or is, as far as testing purposes, is it only anorexiants and weight loss? We're not making a connection to ADHD, narcolepsy, or...
Right, yeah. Your book just talks about weight loss. And like used as appetite suppressants.
Okay.
Yeah, that's really all your book talks about with that. But as far as I know, they're not really FDA approved for that. They're just used for that.
Okay.
That makes sense.
Yeah, I'm just making sure there's no correlation between the 3 disorders that we already discussed.
Oh, no, yeah.
Okay, thanks.
Yep. I'm really hoping.
Are used for weight loss, just not long-term weight loss.
Yeah, not long-term weight loss. Anorexiants should not be used long-term. Is this gonna work? Oh, it's working, but the sound isn't.
So good. I love it. Her like 12 patches of caffeine.
Yes, why isn't the sound working?
I would guess
It totally is. I've got it playing now, but it's not working. Is it working for you guys online or is it silent? No sound. Ah!
So, Corby, you may have to go into your settings in your advanced and scroll down to where it says media and click that says allow sounds in web pages. That's the way mine. This is the exact same thing that happened to me last week. Why it wouldn't do it? And if you click that, it should allow the sound. Does that make sense?
Yeah. Where do I find that?
So it's in your settings under Internet Options.
Oh.
Down at the bottom, and click into it. It has little tabs in the box. So there's one tab that says
quality.
you know when you're there.
I've seen all those shows. Doug. I'm also waiting for no one to soon. There was Doug. Don't know. I'm waiting for it. Well, I heard it's one of the biggest sales.
Okay, let's try that.
I have never got it. They're like, buy one, get one or something. Hit me up. I'll go. Okay, that way your bros are coming over. Oh.
Debbie, I'm not finding it.
You can't tell.
Here, just a second.
I know, bro. Relax. I don't need that.
Sorry, guys. I deeply apologize.
You don't need it. You want it. Exactly. Included. Yeah, I like that.
Oh, hi, Debbie.
How are ya?
Hey there. I'm good, okay?
So if you go down here, internet options, in the type to search, and type in internet options. Right there. Click into that, click into advanced, and then scroll down to where it says media. Okay, play sounds and web pages.
Stupid.
And then hit apply.
You know what? I bought some of mine on sale too.
And then back, it should play.
I'm over here. I'm over here getting on your.
I wonder if you have to restart it.
Oh, I might have to.
Sorry, that's how it is. Okay, I have a question. What's ginger used for?
Huh?
What's ginger used for?
I have no idea.
Nausea.
Nausea and diarrhea. That's what it's used for. You know how many of you guys put it down as an adverse effect?
I did.
Yeah. So we're gonna have to drop that question. I said, look at your CAM document. It came right off the CAM document. Right off the ginger.
Right off the ginger.
Right off the ginger.
You don't like that.
Okay.
Yeah,
It's almost.
that was my category.
Okay, guys. Guys, it's almost 11 o'clock. Let's just take another quick break. I'm going to try to fix this because I do have another video to show you, and I want it to go. Jared, was that like a big sigh?
No, I was laughing.
Sure. Is it Jared? No? Jaden. Oh, I had a Jared last semester. I had him last semester and I get them mixed up. It's okay. I had a Frank last semester and I called him Fred and I felt horrible. Yes, and I called him Fred. Okay, let's do a quick break. We'll figure this out.
Oh, you got the sour burgers?
You ready?
No, you decided that you got this.
She was actually dying.
Yeah. They're like, your body's like the sausage right now. It was eating itself before it eats out. What you had, I was walking around the corner and I go,
That's too crazy.
like, I'm a puncher when I get scared.
Okay, here we go. Oh, I need to mute.
From anything keeps us awake
Not caffeine patches, but there's caffeine mints. Mints. I just happen to have some. They're called Viter Energy, and they're fresh breath mints. And let's see, where does it say?
There's turbo truffles.
Two of these equals 1 cup of coffee. So I have these in my office. They are like breath mints. They have like a slightly weird aftertaste, but if it's caffeine you're looking for, it's totally doable. I just got those off of Amazon.
This adds
Is
this our learning activity for the day?
Yeah.
Did none of you guys get any of that?
Yeah, develop.
Oh, I know I didn't. Most of the time when I share a screen and I play it, it echoes. And so I mute. Did you guys not? I'll post it. I'm so sorry. I'll post it. I'll post the Adderall one too. I'll post them all. Because chances are I won't have this fixed by the end. I know. I'm telling you, it works one week and then it doesn't work the other week, and I don't understand it. Okay. I think. Oh, we've got one more slide. Don't know what happened there. Okay, here's our theophylline. Now what is my blue, what are my people seeing? Not theophylline. You guys see? Oh, there's the theophylline. Okay, so theophylline's mostly used for what? Respiratory, but for what kind of patients? COPD patients. Most of the time you're going to see the caffeine used in the neonatals and then the theophylline used in the COPD. Can be used in some asthma, status asthmaticus. This isn't, like we talked about before when we talked about asthma, not usually used very often. Avoid alcohol and almonds. Okay. Given orally or intravenously, it's not an inhaled medication. Okay, since that was a little rough getting through 19 slides, do you guys have any questions? 19. No questions?
So,
Don't hear me. What?
I don't know.
Okay, so the apnea medications are the analeptics, right? The theophylline and the caffeine, raised for the apnea. Mm-hmm. For ADHD and narcolepsy, you're going to see the amphetamines and amphetamine-like. And then there were the anorexiants, which is a CNS stimulant, which is used for weight loss, but not FDA approved.
So it's not
specifically.
ADHD, narcolepsy, or apnea. Anorexia. It's for weight loss, but it's not FDA approved for actual weight loss. So it's just thrown in there.
Okay.
Just for hacking.
Sorry, that unit was really rough. I thought we could just breeze through it, and the video thing threw it off. I know. Okay. Depressants now. Now we're going to talk about depressants. Yes. Benzodiazepines. For the love. We just need to open it up now. Kind of. Okay, so that's
I legit hated that class more than I hate pharmacology. Wendy's class.
for the test.
Yeah.
Yeah, no. Debbie should by Debbie should soon.
Yeah. Oh, I was okay.
All right, my big blue friends. There we go. Okay. Well, that was painless to bring that up. Okay. Unit 15, depressants. So this is chapter 18. Chapter 18, and it's a tiny bit longer, but still pretty not too long. Okay. So, learning objectives. You guys can do this. Okay, an overview of CNS depressants. So, they cause a reduction of functional activity within the CNS. So now we were talking about CNS stimulants. We're talking about CNS depressants now. Okay. So the degree of depression depends on which drug is being used and how much is being taken. So dose dependent. Okay. Now there's a lot of different CNS depressants out there. A lot of them we've talked about already. We've talked about opioids before, anticonvulsants. And in this section in Unit 15, we're going to talk about sedative and hypnotics, general anesthetics we're going to touch on. And then in Unit 16, it goes through the antipsychotics and the antidepressants.
Why are they?
Because those are the ones we're talking about
Oh,
in this unit.
okay. They're important.
Okay, so there's a lot of different CNS depressants, but the only ones we're going to talk about are the sedative hypnotics and then the general anesthetics. Okay. Okay, so this section really talks about CNS depressants for sleep disorders. So mostly just insomnia. Okay, so here's our stages of sleep. Stage 1, you're starting to kind of get drowsy and, you're just kind of drooping your eyes. You're kind of there almost, right? Stage 2, falling asleep deeper into stage 5, which is your REM sleep. And we cycle through all these different stages multiple times through the night. Okay. So those are our stages. Now, if we say we're sleeping and we get woken up in stage 4, when we fall back asleep, we start over again and go through stage 1, stage 2, stage 3, stage 4. So whenever we get woken up or we wake up, we start over again. Which is the most important stage of sleep?
REM.
The REM sleep, right? REM sleep. That's where you get your muscle paralysis. It's when most people dream. Okay, so non-pharmacological methods for sleep disorders. I always say to keep a schedule, right? Keep a schedule in nursing school. Go to sleep at the same time, wake up at the same time. Or with kids, right? Those of you who have kids, that's funny too.
He has a schedule. I don't.
Right. They have schedules, you don't.
I mean, I wake up at the same time, but then I go to sleep.
Right? Babies mess it up. You're waking up every 2 to 3 hours. Life in general, right. No naps or very few naps and keep them short. Okay? If you're sleeping all day long, you're not going to be sleeping at night. Avoid drinks with caffeine, alcohol, and even nicotine 6 hours before bed.
Oh.
It is, but it doesn't help with insomnia, really. Like,
I pass out.
that could be arguable, but in your book it says to avoid alcohol within 6 hours before bed. And it might be, I think it's not necessarily like it'll fall asleep. I think it messes with your stages of sleep, and you're not in your REM sleep enough, and your quality of sleep with alcohol is a lot less. And without it. Avoid heavy meals and strenuous exercise before bedtime. Do calming activities, warm baths, white noise, decrease noise that's around you. Put your phone away, right? That blue light, even with blue light filters, that phone keeps you awake. Okay? Put your phone away, turn off the TV, decrease noise, avoid copious amounts of fluid before sleep. Why do you think that might be? Because you got to get up and pee in the middle of the night.
But then warm milk.
Well, this says copious amounts of fluid. So
Does anybody here ever drink warm milk? No. I'm judging you.
warm milk is disgusting, but I have gotten up and drinking a cup of milk, like a glass of just cold milk. And it seemed to work for me when I did that. So anyway, non-pharmacological ways to help sleeping disorders and to help you sleep better. Okay, but what if that just doesn't quite cut it? What? Have a question? Yeah.
It says no strenuous exercise before bed. Does it include sex? Because that also seems to help you sleep.
But there's like a lot more like endorphins and like stuff.
Really?
I
I
think
just didn't know if it's included because I'm like, is this supposed to be a morning thing? Because it makes you tired.
That's a good question. I don't know.
I'll research that on my free time.
I'm thinking more like you don't want to go out and run 8 miles or, do a whole lot of like heavy weightlifting. For a lot of people, sex does help you sleep. So I don't know. Everybody's idea of strenuous is different. So you could try it without, try it with, see what kind of sleep you get better at. Okay. So sedative hypnotics, they're kind of put together, but there are a little difference with them. So sedatives are drugs that promote relaxation. They're used for calming effects to relieve irritability and or anxiety. Okay? These types of drugs are used mostly during the daytime, first prescribed to reduce tension and anxiety. So these are more of your anti-anxiety drugs. Okay? And we have hypnotics. It can be the same drug. It just depends on what you're using them for. Okay, so the same drug can be used as a sedative. It can be used as a hypnotic. Does that make sense? So hypnotics are higher doses of sedatives. And the main purpose to use hypnotics is to induce sleep. Okay, they can be short acting, intermediate acting. Intermediate can cause residual drowsiness or maybe a feeling of a hangover in the morning. And hypnotic drug therapy should be short term. Now, when we say hypnotics, we're not talking about like hypnosis. We're talking about sleeping. Okay. Okay, so these types of drugs, they're most commonly used to treat sleep disorders. Okay, some of these drugs at low doses can cause sedation without consciousness. And when we talk about sedation, it's a mild form of sedation. Okay, you're not like falling asleep. It's more of a depressant versus sedation, but your book does call it a sedation. Okay, most of these drugs at increased or higher doses can produce a hypnotic effect, help with your sleeping. Okay, and like I said, they're usually the same drug. And at very high doses of some of these drugs, anesthesia can be achieved. Okay, so there's a difference. There's a difference between sedatives, hypnotics, and anesthesia.
Stages.
Yeah, they're like stages.
And
So-
it's based off the dose.
And it's based off of dose. Correct.
Stage 3.
Okay, so drugs in this category. We have barbiturates, benzodiazepines, non-benzodiazepines, and then melatonin agonists. Okay? All right. Okay, so common side effects of pretty much all sedative and hypnotics. You can get the hangover, dose dependent, right? You can get the REM rebound, which is, oh shoot, I had this written down. Question, yes.
When it comes to hangover, what is the definition of like the side effects or
Residual tiredness. So hangover here means like a residual tiredness. You just are still drowsy. Doesn't include the vomiting and Jenny, did you have a question?
No, I was just gonna say REM rebound is when body hasn't gone into REM. That'll be the first stage that the body tries to make up for. So they'll cycle directly into REM, and then they'll cycle for several hours until it's made up.
And you can get nightmares and
the bad effect?
nightmares and confusion and stuff like that. Yeah.
It is a good thing because if you get depleted of it, if you bring that you have some medicine.
Right. Okay. Okay. Yeah, just a lot of these can produce some dependence and tolerance, excessive depression, respiratory depression, and you can become or develop an allergy from them. Okay, barbiturates. These are your barbital drugs. Who remembers a barbital drug? Phenobarbital. Okay. So these were introduced in the early 1900s. These are classified as long, intermediate, short, and ultra short. Okay. So they should be restricted as far as a sedative hypnotic. Some of these are used for seizure control. So that's a little different when it's used as a seizure control. But as a sedative hypnotic, they should be used short term. Okay. They're now less frequently prescribed because we have lots better stuff going on. Barbiturates increase the CNS depression and confusion in older adults. A lot of these medications in older adults, because their metabolism is slower, their kidneys and renal function and liver function are decreased. You're going to want to be careful with the doses and decrease the dose. Who is at the door?
There's nobody over there.
Okay. So you guys are just being mean to me. That's cool. Okay. That's fine. That's all fine. Okay. So let's see. They have a lot. These barbiturates have a lot of drug interactions too. Okay. So just some things to know. Now, in your drugs to know, you don't have specific barbiturates to know. It's just the drugs, the classification in general. Okay. So know kind of what they do. So we have our long acting, which is the phenobarb, the short acting, and it kind of tells you what they're used for. Obviously, with any type of depressants, you're going to want to monitor their vital signs, monitor their respirations, stuff like that. No, he overdosed on propofol, which is also an amazing drug. It looks like milk.
What is that for?
Like white. That's an anesthesia. Anesthesia. Yeah. Very short acting anesthetic. They use that a lot for any of you guys who've had any type of GI scopes. Use that a lot in GI stuff. Use it a lot in the ICU too, with intubated patients because they can turn it off and it's really short acting. So the patient will wake up rather quickly and then they can do like extubation trials. And then it is quick acting too. So then if it doesn't work, they can just turn it on, give it back to them, and then they're fall asleep. So really great medicine though. I can understand why he liked it. Good stuff.
Why did he have it then?
Why are we going down the rabbit?
Well, he had a personal doctor too that I'm sure he got it from too. No, it's usually used like in the hospital for procedures. Yeah. So I think his doctor went to jail for it. Yeah. Because he was supplying it and he shouldn't have, because it should not be used at home. Okay. So a rather short section on barbiturates. Just know it has a lot of side effects. Let's see. So then we have our benzodiazepines. These are your PAMs and your LAMs. So throw out some med names. Lorazepam. Alprazolam. Ativan. Alprazolam. Okay, there's a lot of them. Let's see. Yeah. Lorazepam, alprazolam. There's a whole bunch of them. Diazepam. All your PAMs and your LAMs, okay? These are a little bit newer drugs, which probably means what? Less side effects, okay? They were introduced as anti-anxiety agents. They can, so they decided, like looking through this and saying, okay, they're used as anti-anxiety. Anxiety can be a cause of insomnia. So if you're able to decrease that anxiety, a lot of people are able to fall asleep. And so that's kind of where they made the correlation between, oh, these can work, these can help for insomnia too. Okay, these guys increase the action of GABA in your brain, okay, which reduces neuron excitability. So you calm down, right? What else affects GABA? Do you remember? Gabapentin.
Neurological disorders. So,
Right. The drugs to help treat seizures, right? Like valproic acid, the Depakote, gabapentin, stuff like that. These do kind of the same thing. These can suppress the stage 4 of sleep and can result in vivid dreams and nightmares. Okay. Except temazepam. Just so you know. That's just a fun fact. Okay, fun fact. Okay. Temazepam is a fun fact.
Okay, so you do need to know that they cause.
Yeah, they can suppress the stage 4
And cause nightmares.
and cause nightmares, but the temazepam is a fun fact. Okay. Okay, let's see. These can also cause sleep-related behaviors. What are considered sleep-related behaviors?
sleepwalking.
Sleepwalking. Sleep talking? Oh, some people just do that in general. Any daytime activity that you're doing while you're asleep. Those are called sleep-related behaviors. Okay, should we see how well this works?
Have you ever seen 67X?
Yeah.
She's on the first side.
She's attention getting workshop.
All right. I will just I'll post all these videos and then you guys watch them. They're really interesting. They really do help explain the stuff. Okay. So, let's see. Increase the activity of GABA, can delay the REM sleep. Effective for sleep disorders for several weeks, longer than sedative hypnotics. They're still considered short-term use though, okay? Promotes relaxation and sleep. So these alprazolam is used in a small dose as like an anti-anxiety, like for anxiety attacks, stuff like that. That's where you get the sedative during the day, right? You can take your low dose. For a hypnotic, you're going to take a higher dose at night. Okay? Obviously, it's a depressant, so you can have your respiratory depression. Contraindicated if you already have problems with your respiratory. Alcohol, drugs, Other CNS depressants you don't want to give with alcohol, muscle relaxers, anti-anxiety meds. Yes, go.
So if you took a high enough dose of Xanax, could it become an anesthetic?
Yes. They don't use it as an anesthetic.
I know.
It'll just suppress you enough. You could die from a Xanax overdose.
I was just curious because it's called a sedative hypnotic. So like obviously you could do like a sedative, which will help you relax, and then a hypnotic that'll put you to sleep.
Yeah.
So I was just wondering.
Yeah, and you can go further.
Yeah, but it's not what it's used for.
Right, but yeah, it's not. They don't use this as any type of anesthetic. Yeah. Should not be taken every night. Why? If you're taking it all the time, what do you develop? Tolerance and dependence. Okay. Avoid performing tasks. No driving on this, guys. Don't sign any important paperwork. Anything like that. Now, there is an antidote for benzodiazepines, but you need to know. Can all you guys see that? Flumazenil. So benzodiazepines, antidote is flumazenil. The brand name is Romazicon. Do you need to know that? This is not on your list of drugs to know, but put it on your list of drugs to know. You need to know that is an antidote. There could potentially be an exam question on that.
Thank you for telling us.
It is good to know.
No, serious, like that helped.
I try not to change them as much as possible, but this one failed to make the list, and you do need to know that this is on the list, okay?
If it's not on the list, I'll usually just ignore it.
Yeah, so definitely put that on the list, star it, circle it, whatever you need to do to know that you need to know that this is an antidote for benzodiazepines. Okay. Let me brush over, let's see. All right, any questions about barbiturates or benzodiazepines? Okay, fantastic. We'll move on to non-benzodiazepine hypnotics. This is your Ambien, Lunesta. Who's heard of those things? Yeah. Zolpidem. It's out in generic form now. So these are your non-benzodiazepine hypnotics. Now these are not used as an anti-anxiety sedative type thing. These are strictly hypnotics. Okay, so they're approved only to be used short-term treatment. However, there are people and physicians that prescribe it and are on it long-term. They'll take it every night. Okay, has a rapid onset of action, so you want to take it right before bed. Don't do anything that requires attention. Driving, signing paperwork, posting things on Facebook. Log out of your stuff before you take this, right? Okay, so they also have a CR. What does that mean? Continuous release, right. So they do have oh yeah, it's right there. Sometimes I forget that I put stuff on there like that. Okay, continuous release. So it has like that coating, and it just slowly, continuously releases the medication, so it'll last longer. Okay, kind of like extended release. I know with the words, oh goodness.
Great actor.
For the love, stop. Okay. Okay, also with older adults, decrease the dose on this. It affects them more because, once again, their metabolism's down, their renal and hepatic function is decreased, so the drug can actually accumulate in their system and be at higher levels. These especially can cause sleep-related behaviors. When they very first came out, there were tons of stories about how people would drive on them, like sleep driving, I guess. A lot of people would binge eat in the middle of the night. just do a whole bunch of different things. So you want to be careful with those sleep-related behaviors. And then another drug that very similar is the Lunesta. Azopiclone. I think both of those, or maybe it's just azopiclone's on there on your list, but I'll need to know, especially the sleep behaviors, because that's these are also, you can become dependent on these ones as well. Not quite as strong as like benzodiazepines and barbiturates, but you can still kind of get hooked on them. Okay, there's a black box warning on here for pulmonary edema. Strictly used to treat insomnia. Let's see. A lot of the adverse effects: daytime drowsiness, lethargy, impaired coordination. There's your binge eating. Erectile dysfunction can cause the tolerance. Yeah.
My brother has to take it sometimes.
It works really well for a lot of people. Yeah.
I just thought you were crazy stories.
Yeah. So anyway, even though it is short term, you'll get people that are on it quite regularly. Okay, now we're here to our melatonin agonists.
Yay!
This is a really cool drug, guys. It's Ramelteon. Okay, it's the newest category of sedative hypnotics. It's still a prescription, but it's not a controlled substance. All the other ones we've talked about are controlled substances. This one is not. Okay, it's FDA approved for long-term use, where all the other ones were short-term use. This one is long-term use. Okay, it's not controlled. It works by binding to melatonin receptors. Okay, it helps regulate circadian rhythm. You're gonna need to know all, like this slide is a golden slide for you. Okay, so it's the only one FDA approved for long-term use. It's not a controlled substance. Works on the melatonin receptors. Helps regulate circadian rhythm. Helps regulate a normal sleep-wake cycle, which is your circadian rhythm. Does not interfere with your REM sleep. Does not produce physical dependence. And you don't get rebound insomnia post-treatment.
How come this isn't one that's prescribed? What slide number is it?
This is slide 17.
17, bro.
Yep, slide 17. So this should be prescribed.
It sounds like it's a lot better of a drug than Ambien for sure.
Yeah, this is.
Cost or?
I'm not sure about cost. That'd be a good question. I know Zolpidem. I know that's pretty cheap and readily available. I'm not sure about this one, but instead of working on your CNS, it works on your natural melatonin stuff. Okay. And then here's another video just about melatonin in general. Your book does not cover just melatonin, because you can buy like the melatonin over the counter, and they give that a lot to kids to help them sleep and calm down. Your book just really goes over more prescription stuff and regular, like the melatonin supplements.
There isn't any studies done on how melatonin affects the kids who do have ADHD. Because like for me, it would take a lot longer to actually kick in. Like I would take it at 6 p.m. and I wouldn't fall asleep still until like 2 o'clock in the morning, and it would hit me and it would hit hard, and I'd be like super tired throughout the day.
Really?
Yeah.
Interesting. I'm sure there are studies. I'll have to look into that. So as far as just taking like a melatonin supplement, your book doesn't cover that. But I do have a video right here. Of course, we've realized the videos don't seem to work very well. So I'll make sure I post that and you guys can read about that. Okay, So melatonin and like I said, this really isn't in your book, but I'm just covering it because a lot of, especially kids, because you don't want to give any of the ones we've talked about before, you shouldn't be giving them to kids. So really the only option for kids that have problems is just the plain melatonin that our body already makes. It's just boosting that a little bit. So it is a normal hormone secreted by our own body that helps with our circadian rhythm. Okay, and it's based a lot on the lighting and how your body reacts to the lighting. Okay, so it's stimulated by darkness, and once the lights go down and it starts getting dark, that's when your body's like, oh yeah, let's produce this melatonin and get sleepy and tired. So it's kind of your body's own way of doing that. And so melatonin, we make it synthetically to help mimic that and help us fall asleep. And it's available over the counter. So just be aware of that, because a lot of people actually, especially those who don't want to take medications, or if they're children, they'll use the melatonin instead of prescription meds. Or Benadryl. Okay, any questions on depressants as far as sedative hypnotics? Yeah, so melatonin, it is like where it's a natural hormone, you don't get addicted to melatonin itself. The melatonin agonists, no. Did you guys see that? Oh, you can't see it. Debbie just put there's one other question that will be dropped as well.
Yeah.
Okay. All right, so at the very end of that chapter, it covers anesthetics. It goes in a little more detail than I'm going to go through, just because a lot of these anesthetics are done in the OR. A lot of them are like IV stuff, so not necessarily PN level. But there is 2 different types of anesthesia. There's general and local. What's general? Whole body. What's local? Right. Okay. So general's all over, affects the whole body. Local is just
The general public versus
your local house, right? Local's just in one spot.
local store.
Okay. Used to depress the CNS, alleviate pain, and cause loss of consciousness. Who wants to be conscious during surgery? Not me. Not me. The first anesthetic was nitrous oxide. It's great stuff. It's still used most often in dental offices.
It's the laughing gas.
Laughing gas.
Shit's so fun.
It's also used in cars to make them fast.
Why would you breathe that in?
Just,
You got that going on.
side note, nitrous. Get your shot of nitrous through your engine, and anybody who's seen Fast and the Furious, it's NOS. Yes. Yeah, NOS. They exaggerate the whole nitrous thing, but it still makes it fun. All right. So as far as anesthesia go,
Do you have that in your car?
no, but I have had cars with it. Yeah. I do have bottles at home with it. Yeah. Anyway, I've owned over 70 cars. 70. I think we're about at 78, I think. Most of them Mustangs. Anyway, I've owned. Yeah.
Harvey, what the hell?
I own 13 right now.
What? Wait, we gotta go back over.
Take a second to discuss my car situation. Do I race underground? I used to. I used to be a street racer. Yeah. Yeah, I autocross now.
Wait, is autocross for like the desert race?
Oh, no, it's rally racing.
Oh,
That would be amazing. I would love to do that. So in autocross, they usually do it in a big parking lot because that's like the biggest.
a big empty parking lot, and they'll put cones through it, and you have to drive the course through the cones as fast as you can.
So Tokyo Drift.
I have a video of my son doing it just 2 weeks ago. We went and did it, and he did it 2 weeks ago.
Or post that on the module. Yeah. It has to be on my outside. You have to know about it. Everything is learning right now. It's educational. It is so educational.
Okay.
Wait. Why do you have 13 cards?
I'll post it.
For that reason?
Okay, well, let's see. So one of them my husband had since he was 13. He built it. It's a little 57 Chevy truck.
Cute.
It's purple. He painted it purple. Can you believe that? Anyway, and then we've got my son. I'm counting my son's car because he's still 15. But my son has a car. Okay, you really want me to count them all?
Yeah.
I think I have 13. Okay.
We have time. It's fine. Do you live in a parking lot too?
So, okay, so.
But seriously, you have like a garage.
Yes, I do. I have a really big shop behind my house. Okay, all right. I got to keep track of these. Okay, where am I going to start?
I'll write them down. Your son's car.
Okay, so my son's car is an 87 Mustang. My husband has a 79 Pace car and the 57 Chevy truck.
Pace car.
A Mustang. A Pace car. Those were, yeah. And then I have an old, I don't know, 80-something Bronco that's white. I have an 89 Mustang Coupe.
I feel like you like Mustangs.
I have an old convertible that actually we're parting out, but technically it's still a car. Let's see what else. Oh, my 88 GT Mustang we just bought like a month ago, which is what my son was autocrossing. Let's see. And then I have a 2013 Raptor. Yeah, Ford truck. Oh, so fun. My husband has a work van. That counts. He owns his forklift business, so he's got a work van full of tools. And then I have my 2014 Mustang that I drive. You guys, the white one that's out there. And then I have a Ford Journey. That's a family car. It's the only car that will hold all of us. A Dodge Journey.
Seriously. You know we got time for that. Insurance and registration.
And
You live at the DMV.
I do. In fact, my car needs to be registered right now. It's expired.
You got another choice. Yeah, you got like.
Is that it? Did I get them all? Do I only have 11? You just have 11? We do have a boat and a trailer. Does that count?
Commenting on our discussion here.
What did you say?
I can't read on my thing. Can you pull it up? I'm trying. Love the gas. Rebel. I vote for something.
A learning activity, auto racing in a parking lot.
Yes.
I think that's it.
Does your Mustang have that thing where like
So maybe we just have a
does the Mustang light on the ground?
My white one does not, but we've had them before. Now my husband has he's a mechanic too, so he'll build a lot of wrecked cars and then sell them. But one of his most notable, he had a 93 Cobra Mustang that made it into a magazine.
Wow.
So anyway, it's fun. Anyway, it's really fun. It's a fun hobby. It's expensive. It's an expensive hobby.
Sorry, that's very personal. Do you like get cash for them or how do you?
Yeah, because we'll buy and sell them,
Okay, that's 70.
and we just kind of turn them over. Yeah,
You car flip. Oh.
I do.
Okay.
I guess that's technically right. I car flip. I
So
car
much
flip.
about you in like 10 minutes.
One of my first cars, I have a picture. I'm trying to make like a montage picture of all of the cars that we've owned, so I can put it in my office. But one of my first cars, I have a picture of it it was my little Bimini blue
Your office?
Mustang. Yeah,
I'll stop by.
just sitting there. Okay.
No, I want to say no.
Any other questions about me and my cars?
so many, but I
You
don't.
do or you don't?
Any questions about my cars? Any other
Oh, I
questions?
thought you said you named them.
Um,
That's what I said.
we don't. Well, we kind of. Some of them do have nicknames. Like I have this white one out here, and then I have my '88 white one that we just bought. So that one I call number 2 because they're both white. So I'm like number 2. I call it number 2.
My car's named Jarvis.
So there's a few of them we've named.
You don't have one?
We did have an old Dodge truck that we named Doug.
Doug.
So anyway, okay. Back to anesthesia and nitrous oxide. Okay. So a balance of anesthesia is usually achieved by a combination of drugs. Okay. So you're not necessarily, when you go into surgery, you're not going to get just one drug. That'll be a combination. Usually you get like Versed and fentanyl and Versed are usually good together. Ketamine, propofol, all that good stuff. Okay. And then because it does, they do give you sometimes some drugs to paralyze you, especially if you're intubated. They want you paralyzed. So if you're paralyzed, you can't breathe. So you'll want to monitor vital signs, respiratory rate, blood pressure, oxygen level. And then here's your 4 stages of anesthesia. You have just sedation. Now, when you're a nurse and you give opioids, you give any type of depressants, whether it's anesthesia level or not, you have to do what's called a NAMDA score, where it rates their level of consciousness, basically.
NAMDA?
NAMDA. So, yeah, so like N is like there's no sedation, then there's A is anxial something, anyway, and then it like goes down from there to, I don't know what all of them are. I probably should. When it comes up on charting, it lists them all. Most of my kids are awake and fine. 67 fastback. What? Shelby, if you ever need to get rid of that, you just let me know. Shelby, I feel like you and I need to talk. Yeah. So it sounds like your husband's kind of like or fiance. She say fiance. Is like a mechanic guy. Which I'm telling you, if he's into Mustangs, chances are he's heard of my husband. Like, it's crazy, guys. It's so crazy because like they'll buy and sell parts, and like down the road they'll be like, oh, this starter was so and so's, which was so and so's, which was bought for me, and I'm like, what? It's a freaking starter. Or like, and anyway, it's crazy. They keep track of the parts and where they come from and who sells them. And wisdom teeth extraction. Probably, I would say stage 3.
I had mine out. I was waiting for that shit.
I guess it depends on, because like if they're impacted and they have to dig them out, you're gonna be.
Oh, he used my jaw as leverage. I was waiting for that. And I
Wow.
felt the last one.
Maybe you should get a new oral surgeon.
He's like, they have me with doors, and they're like, how do you?
I was completely put out for mine, and a lot of
My insurance didn't cover it, so I just got the numbing.
Oh, okay. A lot of wisdom teeth extractions, like they'll start an IV and do meds through the IV to get your black with gold stripes.
My roof was twisted, so they had to cut the doors.
Chad, Steph, that name does not ring a bell for me, but it might for my husband. I'll ask.
That looks fun.
It's pretty.
I also currently have 640 in my car, so it's like something perfect, like electric.
Okay, so a lot of these anesthesia, depending on what dose you get, your book says that you can go through all 4 stages of anesthesia. Now, according to this, the 4th one is death. And honestly, if you didn't have support, as far as like breathing support and stuff like that, you would die. But where we have like intubation and your anesthesiologist is taking care of you, you're not necessarily actually experiencing death. But if you didn't have that medical support to help you, you would die. Does that make sense?
Yeah. Facebook stalk you later.
So don't. I think I have pretty high privacy settings on my stuff. Okay. So anyway. All right, back to anesthesia. Let's see. So there's a lot of different ways to get anesthesia. You can have your balanced anesthesia, which is a combination of drugs, right? You get the additive effect. You can inhale it, which is a nitrous oxide. That's inhaled. You can get it intravenously. You can do the topical, right? Those are more like ointments and creams. Local. Anyone ever have a nerve block or anything? Rachel had one to do her knee.
I've seen patients that have had them.
Yeah, they're great. They're amazing. I've seen one actually done, and it does not look fun to actually have it done. But the results in the end, I mean, you're completely numb. And then you can do spinal, which would be your epidurals, which you can get spinal headaches from. Now, on your drug to know in your anesthesia is lidocaine. You guys should know that that's already lidocaine's for anesthesia, right?
Yeah.
They have it as topical. Yeah. They have it a lot in like Oragel. They have like a benzocaine, lidocaine type thing. And like Oragel for your teeth. You can get it in ointments and stuff like that. Okay. So like I said, just a touch on anesthesia. We're not going in a whole lot, and then the drug in there. So that is unit 15. Any questions?
I added you, but not just this talk. I found out we were already friends.
Okay.
Lunch. Or I gotta eat.
Jessica, did you have a question?
No, Jess, it's lunchtime. Tell Jess if she was here, she could ask her question.
No, I was just saying that I've had a nerve block before.
Oh, okay. Was it painful to place?
I don't know. I was under general when they placed it, and I'm very grateful.
Okay.
I had 2 nerve blocks though, and now I have nerve damage from it, so.
Oh. Yeah.
Jess, you
worth
took
it.
into class and you could have taught us all about it. Huck Corp, she should have.
Megan, I'm sorry.
There's Ashley too.
I miss all y'all.
Yeah. This is a shout out to
miss you guys
Olivia
too.
and Emma and Jess. There's 3 empty seats where you're supposed to be sitting.
Call them out more.
We're going. We're gonna go get some.
Start. Hopefully this will go through quickly.
The other guys were real short.
Okay, so what we're going to do is, because we've already talked about, we're going to skip around a little bit.
Oh.
Because we talked about depressants, right, just recently. We're going to skip to slide 22 and talk about anxiolytics. Okay. And why do you think maybe that might be? What did we learn about depressants that might? They can treat anxiety, right? Dose depending. So it can either be a sedative or a hypnotic. We talked about hypnotics. Now we're going to go back and talk about it being a sedative for anxiety. Okay. So we're going to skip to slide 22 of my Unit 16 slideshow. Or slide 21?
Yeah, mine says something weird.
Okay. This is my slide 20. Somewhere around there, you'll see this slide.
It's 21.
Okay. So, talk about anxiolytics. And this is chapter, 19 in your book now? Nope. Slides 23. 22. 22 and 23. So, anxiolytics are in 22. Chapter 22.
So, 3 units. So there's like, what, 2 chapters per unit?
There's 3 units, 4 chapters. So Unit 14 is chapter 17, Unit 15 is chapter 18, Unit 16 is 22 and 23. Okay. I know, right? Okay, so anxiolytics, we start on, this is on page 289 of your book. So we're going to talk about anxiety. There's a couple types of anxiety. Your book talks about 2, primary and secondary. So primary is not caused by a medical condition or by drug use. Okay. Secondary is related to drug use, related to medical disorders and psychiatric disorders.
I'm just trying to figure out how do you know which one's which.
And we'll talk about that in a second. Okay. So non-pharmacological measures to treat anxiety. Throw them out. Therapy.
Talk to your mom. Call your mom.
Breathing exercises.
I called my mom and she's like,
Breathing exercises, aromatherapy. Jenny, what did you say? Shopping.
That's good.
Shopping, as long as it's somewhat controlled. Alcohol, maybe not the best treatment for anxiety.
Pet therapy.
Pet therapy, music therapy, meditation, working out, exercise is huge. What about just like plain sunlight? Who gets that, like, and this works for depression too. There's a lot of things that cross over into depression too.
Decrease the anxiety in your life.
Decrease anxiety, learn how to say no. Right?
Oh, there you go. I don't know how to learn how to say no.
Learn how to say no. Okay, so a lot of different non-pharmacological measures. Some work.
Unless it's work, and then I'm like, no.
Some don't. Depends on who you are. Okay, so anxiolytics are anti-anxiety drugs that are primarily used to treat anxiety at the lower dose, right? And insomnia, which would be the higher dose. I've said that about 1 million times. So if there is a question on the test and you guys miss it, I will hunt you down and gut you like a fish. I'll make you write it 100 times, like Bart Simpson. Okay, benzodiazepines are the most used anxiolytics. Give me a benzodiazepine. Lorazepam. Yep. Diazepam. Temazepam. That's usually used for sleeping. Temazepam. Alprazolam. All that good stuff. Okay. They enhance the action of GABA. I already talked about that. Okay. Are physically and psychologically addictive. Right. Dependency tolerance. Use sparingly. A lot of people are prescribed these for not necessarily an everyday use, but more for anxiety attacks. So they're really good to help with those periodic anxiety attacks that can happen. Okay, withdrawal symptoms from short-term use is different than withdrawal symptoms from long-term use. So short-term use, you can get the agitation, nervousness, insomnia, tremors, anorexia, muscle cramps and sweating. Now, long-term use with high dosing, that's where you get your paranoia, delirium, your panic attacks, You can get some hypertension, and in severe extremes, you can get status epilepticus. What's that?
Seizures, like
Continuous seizure state. Okay. Here, especially in this section is correct on switch and doing the adverse effects versus the side effects. So can you look and kind of see the difference between the two with this section and like with this med, especially, I think.
Yes.
Right. So side effects, you got sedation, dizziness, they're kind of mild. Now adverse effects, you can get this suicidal ideation, the abrupt withdrawal symptoms. Now these can treat status epilepticus, but you can get status epilepticus as a withdrawal symptom as well. In that case, you'd want to treat it with something else, right? Okay. Off-label use, withdrawal from alcohol and illegal drug abuse. Okay. Okay, and then Buspar. Your book talks about Buspar. Buspar is pretty good medicine, and it works really well. What? Ah, McKenna saw that. Look at that. Grapefruit. Now, I will warn you, there is a question. One of the options is grapefruit. Now, be very careful what it's asking you. Okay? All right. Or maybe not click it. You'll need to know what you can't take grapefruit with so that you know what you can take grapefruit with. Does that make sense? Okay, contraindications, MAOIs, which we're going to talk about later. This guy does the serotonin receptors, where this guy does the GABA. So, know your mechanism of actions too. Yep. So that's our section on anxiolytics.
That's it.
That's it.
We're done. We can go home.
Well, no.
So how would you choose which one you would use as?
That would be based on your symptoms, what's causing your anxiety, and your doctor. So this one has no risk of dependency or withdrawal. So if you maybe have a history of opioid use or abuse, or maybe want to stay away from controlled substances, buspirone might be your choice over the lorazepam. So it really depends on, it's per patient and doctor, depending on which one you would choose. This one's a pretty good one. Okay.
For like general anxiety, the least filled out for happy that.
Yeah. So. So, Kim, with like primary anxiety, this would be things that more maybe like in things that happen in your personal life, situations you might be in, something that's not caused by a medical condition or drug use. So anything.
Like a natural response to something.
Yeah, it could be like a hypersensitivity response to a stressor in your life, where these types are more.
So like nursing school?
Like nursing school.
That would be primary.
Yeah.
I did get my first anxiety attack the other day trying to study for an exam. So.
Okay, yeah.
Develop like ADHD and like in old age, because I feel like I've gotten that in nursing school.
Yeah, you can. Yeah, ADHD. That's one thing I didn't really cover. ADHD is usually found in like children, like between 7 and 12. But yeah, there is adult onset ADHD. Okay.
So, going back to the ADHD, so I know like sometimes people who have like attention deficit disorder or even like normal anxiety or whatever, they like feel things more than other people. Like they'll feel more anxious than like a normal person experiencing the same kind of stressor because like their emotions are like above and beyond. So would that be part of secondary because they already have like that general psychosis of like ADHD or depression or
Yeah. Yeah. So any type of psychiatric disorder, yeah. Drugs can make you become more anxious too. So some
I'm not on any.
drugs can make you more anxious, which would cause the secondary anxiety.
So I've noticed a lot of these kind of run together. Not but it's like, is there a correlation? Like some people that seem to have ADHD also have anxiety and depression.
Is
that just like life factors or
it can be. So when we talk about we're going to talk about depression here, and we'll talk about things that can cause it. But yeah, they all kind of run together. And this wasn't ever, like when I went through nursing school and stuff, this wasn't really ever a really big unit or really widely talked about. And now it's huge. Like, especially with COVID, we're seeing a whole lot more psychiatric issues and things come up, and we're recognizing it more, where before it was like taboo, or it was all in your head, Kim, it's all in your head, control this. Well, we're learning that it's not, it might be all in your head, but it's not something that you can control. It's like the neurotransmitters that are affected, not just not just like in your head, not just a lot of people, it's not something you can control.
What cracks me up is that people will be like, you just need to like calm down and stop being so anxious about something. And I'm like, trigger word. Okay.
Calm down, trigger word.
Yeah.
Yeah.
Learn how to like work with
just
it,
stop
figure
stressing
it out, or
You're
stop
just
stressing out about it.
Yeah. So it's definitely the mental health, like I said, especially in COVID, but even just more recently in the last couple of years has become huge. And a lot of people, want to be able to talk about it and not make it so taboo. Okay. So I think now we can go back to the beginning. Sorry, I know. We're going back to the beginning. Okay. So anxiolytics fall under this, but like I said, it does pair with the depressants because it's dose dependent. Yeah, so, and antipsychotics too. Okay, so drug used. And let's see.
Several. We have all of them. Several. I have a collection.
Do you guys care if we do antipsychotics or antidepressants next? This is antipsychotics. Okay. All right. So drugs used in mental and behavioral health. We've got antipsychotics, anxiolytics. Then we'll talk about antidepressants too. So psychosis, or some people just, your book kind of does this, just kind of umbrellas psychosis with the word schizophrenia. But we all kind of know there's different varying degrees. There's different types of things. So psychosis is a loss of contact with reality. How do you think that interacts with treatment for it. Right.
Their reality. It's reality. You don't know what you don't know.
You don't know what you don't know. Well, and if you have a loss of contact with reality, do you know what is reality exactly? So if somebody comes up and says, hey, you need to take this pill,
Nothing wrong.
yeah, like they're going to think there's nothing wrong. Or they can go on the paranoid side and say, what are you doing? Are you trying to kill me? Are you trying, like, I feel like you're trying to kill me. You know, like this is going to poison me. And so, yeah, so treatment for this, treating people for this can be pretty difficult depending on the severity of their loss of contact with reality. And so we see some poor success with controlling psychotic symptoms when people are in this state of mind. Okay, so psychotic symptoms are usually associated with more than one symptom. Okay, and some of these symptoms are difficult processing info, disorganized thoughts, delusions, hallucinations, distortion of reality, incoherence, catatonia, aggressive or violent behavior. I'm sure there's more symptoms. Those are the main ones that your book talks about. That's like when you're like in a catatonic state. Yeah. Yeah. They're really hard to reason with. They're really hard to control. Like I said, a lot of people are kind of like in a paranoid type state. What's that one show? What is it? Beautiful Minds? Is that? It's kind of an old show, but it's a guy with paranoid schizophrenia. So if you haven't seen that one and you're interested in mental health, you can watch that. And then anxiety and then psychotic behavior with anxiolytics, sleep disorder, seizures, all that good stuff. Okay. With psychosis, you have what's called positive symptoms and negative symptoms. You'll need to know which belong in which category. Okay, so positive symptoms are exaggerations of normal function. So you're going to get the agitation, incoherent speech, in so much that like they're talking and they're not making sense and you don't understand what they're saying. They're not connecting thoughts. Maybe some of you guys have seen some of this in your behavioral health rotations. Delusions, disorganized speech, hallucinations, insomnia, paranoia. They're hyped up. It's very active behavior. Negative, obviously, is going to be the opposite. You have the lack of pleasure, the lack of motivation. They have a blunted affect, poor grooming and hygiene, poor social skills, poverty or simplicity of speech. They won't talk to you. Maybe they have like a really low, slow, low tone voice. Social withdrawal, maybe excessive sleeping, or maybe it looks like they're like in depression type stuff. So these are a decrease in function or motivation. So antipsychotic drugs are more effective in the treatment of positive symptoms than in negative symptoms, and that's across the board. You not have this slide, Kim?
It didn't show up in transfer.
Oh.
Yeah, it's just the program we use. Yeah.
All right.
Not your fault.
So antipsychotic drugs are going to treat the positive symptoms more than the negative symptoms. Okay, so here's kind of a visual of, they're thinking that it's an abnormal transmission of the neurotransmitters in the head. So especially dopamine, but also serotonin and glutamine. And so here's kind of a, I don't know, is this some kind of scan? Doesn't look like a CT scan, but some kind of scan of showing the differences of the dopamine levels in the human brain from a normal level to an elevated level of the schizophrenic patient. Do they have a lot more specifically in the D2 receptors. Okay. What was that?
The psychosis, schizophrenia, like the positive and negative symptoms was what we learned in Wendy's class.
Oh, yeah. Yeah, some of this will be repeat of Wendy's class. So the importance of dopamine in relation to psychosis is twofold. So antipsychotic drugs exert their therapeutic effects by decreasing the dopamine levels, by blocking dopamine receptors or dopamine antagonists, okay? And they increase, there's also drugs that can increase dopamine levels in the brain, like cocaine, levodopa, we talked about that, right? And they can cause signs and symptoms of psychosis if taken too much. Okay, general characteristics of antipsychotic drugs. They're derived from several chemical groups. They're broadly categorized as first generation typical agents and second generation atypical. Okay. First generation include phenothiazines and first generation non-phenothiazines. First, so typical antipsychotic drugs include all phenothiazines and only first generation non-phenothiazines. So the atypical drugs are only the second generation and newer non-phenothiazines.
Okay, so the first, okay, that makes sense.
You'll need to understand that. So typical has phenothiazines and the older non-phenothiazines. Atypical is only non-phenothiazines, the newer kind. Okay, let that digest for a hot minute. Okay, so the first generation drug, we've all heard of Haldol, right?
Yeah.
Who hasn't heard of Haldol? I'm sure we've all heard of Haldol and how great it is. So that's considered a typical drug. Then we have our non-typical or atypical, clozapine, risperidone, olanzapine, ziprasidone, and aripiprazole. We've got Aricept. Well, I can't think of the brand names of all the other ones. Anyway. And then the most common side effect for all antipsychotic drugs is drowsiness. And that's right, because it's treating them positive symptoms, so it's going to slow them down, make them drowsy, which is what Haldol does very well.
Isn't Haldol also an IM injection?
Yep. Yep, you can give Haldol IM. That's usually how it's administered like that very often in a hospital with security guards holding the person down. Okay. Okay, so here's another slide kind of separating them all a little bit. So the typical has the phenothiazines and the first generation non-phenothiazines. The typical blocks the dopamine at D2. We have, I think it's 5 dopamine receptors, 1 through 5. Either 4 or 5. Yeah, 4 or 5. Anyway, this one blocks dopamine at D2. Increase positive symptoms and cause EPS. What's EPS? Anyone? Not environmental protection services. Yes. The extrapyramidal symptoms or syndrome. Okay, it has more side effects. They are older drugs, so more side effects, but they have less withdrawal symptoms. The atypical is the second generation non-phenolthiazines only, right? Blocks less D2, but more D4. And it does serotonin receptors as well. Treats positive and negative symptoms. Less likely to cause EPS, has fewer side effects, but more withdrawal symptoms, which can be bad because some of these people are non-compliant. So it can
You know why
cause
people
problems.
with dementia have to take typical over atypical?
No, I would think it would depend on the severity of their symptoms and if they're exhibiting more positive versus negative. Once again, more based on the person and their situation. The second generation, they're newer, so generally they're more expensive. That could play a part in it. Money always plays a part in things. Okay, extrapyramidal syndrome. There's a couple different, there's pictures, and then this will explain it. So we have pseudoparkinsonism. We talked about that when we talked about Parkinson's, right? Some drugs can cause pseudoparkinsonism. These are these drugs. And then, so you'd get all the symptoms you would with Parkinson's. And you have acute dystonia. You guys need to know the difference between them. Okay, you get the muscle spasm of the face, tongue, neck, and back, facial grimacing, abnormal eye movement, laryngeal spasms. And then continuing on, we have the akathisia. That's the inability to relax. So you're like obviously tense, but you can't sit still. Rocking, just crossing and crossing legs. It can be mistaken for anxiety or agitation.
Is that the when he shows the video of the guy like walking across the room back and forth and he could not like relax. Does anybody know if
It sounds like it. Yeah, it sounds like it could be. And then tardive dyskinesia. This one is an often irreversible side effect, I guess, adverse effect that can happen if somebody starts getting these symptoms. It's
long-term.
Yeah, you want to stop the medication, but then it's irreversible. So as far as they are in the symptoms, like it's not gonna reverse. So those are, and then here, this is the picture in your book. I think these cartoons are rather funny, but this kind of for all you visual people. Okay, and then one of the bad, it's rare and life-threatening, is neuroleptic malignant syndrome that can happen on these medications as well. Okay, so predisposing factors: excessive agitation, exhaustion, and dehydration. So knowing that, what's maybe some of the teaching that you're going to give families and patients taking these drugs?
Hydrate and sleep.
Stay hydrated, right? Yes.
Don't take
Stay hydrated, right? Make sure that they don't get into a state of exhaustion. Okay. Caused by hypersensitivity or toxic levels. And then these are the things that can happen. So you get hyperthermia, tachycardia, seizures, muscle rigidity, altered mental status, and then you get into organ failure, dysrhythmias, rhabdomyolysis. These are all bad things. So if you start seeing these symptoms, obviously stop medication. Do not give any more, and it's an emergent situation. So life-threatening. I do have a video. I'll post that since we've been having problems. But this shows a guy like actually in NMS. So you can take a look at that. Okay, and then more adverse effects. Sexual dysfunction. Our sexuality is huge, right? Defines who we are, and it's a big part of our lives. And so when that's disrupted, people don't like it. So that's what is galactoria? Who knows what galactoria is? Yep. Lactating without a baby.
Yeah.
Yep, and girls can get it too. Women, we both, both sexes can get that galactoria. Galactoria, however you want to put the emphasis. Huh?
With like breastfeeding moms, like they're usually crying and things like that trigger that leak. So I wonder what like the trigger factors would be for that too.
I would think it would just happen. Yeah. And then gynecomastia. Enlarged breasts. Man boobs and bigger women boobs.
Do those kinds of things happen early on, or does that have to be like long-term use or like higher doses or something?
That's a good question.
Those are pretty serious. Like, does NMS continue?
Is this what?
Does this NMS continue?
No. No, these are just more side effects, adverse effects. Yep. Yeah, so really kind of, definitely you'll want to let them know that this is going to happen before it happens, because it could really freak them out. You start a medication and all of a sudden you're lactating. And you're a man. You're like, what? Yeah, and you get someone with forms of psychosis, or make it worse.
They start taking like steroids too. Yeah, I'm trying to.
Yeah. Okay, so a typical phenothiazine we're going to talk about is fluphenazine. So depending on the drug used within the typical class, not just fluphenazine, but within the typical class, depending on what drug you use, will determine the severity of EPS. Level of sedation, severity of hypotension, dry mouth, urinary incontinence. What does all that sound like? All those symptoms. Anticholinergic symptoms. Right. That would be a contraindication, right? More anticholinergic meds. So they're highly protein bound. Excretion of drug in their metabolites is slow. They have a really long half-life. And so accumulation can occur. And that's when you're looking for your EPSs, right? And your NMS. Okay. So it won't necessarily happen right away. The drug has to accumulate because it's got this large, long half-life. Okay. Anticholinergic properties. It does cross the blood-brain barrier and the placenta and the breast milk. Metabolites detected in urine go up to several months after the drug is DC'd. Because it has a long half-life, right? Color of the urine can change to pinkish to red-brown. Maybe looks like they might be peeing some blood. Old blood, maybe. But it's harmless. It's kind of can be expected. Well, therapeutic effects not evident for 3 to 6 weeks. You can see some improvement within like 7 to 10 days, but the full effects take a few weeks. Okay, so here we've got our fluphenazine, blocks the D2 receptors, manages symptoms of psychosis, including schizophrenia. Here's your adverse effects, and then your side effects. There's a lot of them. A lot of anticholinergic stuff. But for this excess sweating. Yeah, diuresis. Weight gain, urinary retention, discoloration, peripheral edema, the sexual dysfunction, drug interactions, any other CNS depressants, opioids, alcohol, especially. And then you want to be careful with antacids and anti-Parkinsonism drugs. What do anti-Parkinsonism drugs do? Remember? What do they do to the body? What do anti-Parkinsonism drugs do to the body? Okay, but how? How do they do that? What? Okay, so dopamine increases the availability of dopamine, right? So if you're taking an antipsychotic that is blocking the dopamine receptors, you want to take a drug that's increasing the amount of dopamine? No. Well, technically, but they'll be fighting for those receptors. So don't want to take them together. And there's your glaucoma. Glaucoma. Be careful with glaucoma. Any type of brain damage, and then CNS depressants. Okay. And then another typical non-phenothiazine is haloperidol. So it can cause adverse effects similar to the phenothiazines. It's a high potency drug. It has a high incidence of EPS. It can be used as an initial drug to treat psychiatric disorders, or as a substitute for those who are hypersensitive or refractory, not improving, to phenothiazines. IM, there you go, Kim. IM is given for those who are unable or unwilling to take the oral medication.
Oh, yeah. The patient come down from benzo overdose, and he fought a security guard, knocked out a tooth, cut his forehead, and they tackled him and gave him a freaking alcohol.
Yeah. I've seen them sometimes, they don't even pull down the pants. They'll just tackle them and stab them through their clothes. Yeah. So here's your Haldol. Now notice it doesn't say, I don't have nursing considerations. So what are some of your nursing considerations for these drugs? If you're in a behavioral health unit or even just on a medical unit with someone taking these medications. Safety precautions. Don't let them get dehydrated. Make sure their drug is full of water. Yes.
Watch their respiration.
Okay. Yep. It's gonna calm them down and affect those positive. Yep. What about this? They're ordering a Coke.
Oh, yeah. No soda, no coffee.
Maybe say no. Discourage it. Okay, they might have a dry mouth, so what might you do to help with that? A jug of water. Photosensitivity, so what are you going to tell them when they discharge?
Put some sunglasses on.
And long sleeve shirt, sunscreen, right? And photosensitivity is not just with the eyes, it's with the skin too. Blurred vision, insomnia. So when are they going to maybe take this medication?
Oh, wait, no, insomnia in the morning. Sorry, I was thinking blurred vision, you don't want to go throughout your day blind. Driving and shit.
So, it does One of the side effects can be drowsiness, and one can be insomnia. So depending on, depending on how it affects them and when, they can kind of work out when to take the medication. Now, drowsiness does not necessarily mean like hypnotic. If that makes sense. Doesn't necessarily mean that they're just gonna like go to sleep.
So they also can't have caffeine.
I know. These are good drugs, but they're like, you have to manage them closely. I know. I know. All these things to keep in mind. So, I know there's a lot. There's a lot. Oh, now more than ever, you need to know this stuff.
I just get it. It's fine.
Like I said, it never used to be that big of a deal, and now we're seeing it a lot more. The COVID isn't helping. Okay, so now we're on to atypical antipsychotics. We're going to talk about the Abilify. Aripiprazole. So remember, the atypical only includes the second generation non-phenothiazines. Right?
Abilify was on our test.
It was?
An option for something new.
Yeah, that was.
I did see that.
Nice.
That was bad. I was about to click it. And I was like, oh, we haven't talked about it.
There you go, Mark. There you go. If we haven't talked about it, it's probably not the answer.
But it had a frizzle, like the PPIs. And
Oh, like the PPIs?
I was like, oh, it could be the PPIs. But I was like, I don't know. You had me there for a second.
There you go.
Nice try.
Got you doing a double think. Okay, so good at treating schizophrenia and acute mania associated with bipolar disorder. Did you have a question or are you stretching? Okay. Blocks both the dopamine and serotonin, where the typical does just what? Typical blocks what? The typical blocks what? The dopamine. The D2, D4, just the dopamine. Atypical does dopamine and serotonin.
Oh.
Okay, it's better at reducing the positive symptoms and relieving the negative symptoms.
It's confusing because when Wendy taught it, positive symptoms were like what you had to see to diagnose it, not like different ways that they act.
Yep. Yeah.
That's how Wendy taught us.
Huh.
Positive symptoms are things that like you would use as a diagnosis. And negative symptoms are like could go into like any other like mental illness category.
Yes, and like think about it now. But yeah, it might indicate that they have this.
Interesting.
They get Wendy.
So these atypical have virtually replaced phenothiazines and related drugs, except for Haldol, which is still used, at least in the hospital. Okay. So these can trigger diabetes, though.
Ooh. That's no good.
Mm-hmm.
The actual.
And then side effects, weight gain, hyperglycemia. See how the side effects are just like a lot less.
Oh, yeah.
And even the adverse effects, they have a lot less. Although they will still cause sexual dysfunction. Look at that. There it is again. Our friend, the grapefruit. Anna, it's a shout out to you. Look, there's St. John's wort. Mark and Megan and who else did St. John? Victoria. St. John's wort really could be on all of these because it'll affect pretty much every drug.
Is it just on here because it's like like as far as depression and anxiety? That way you have the St. John's wort on here or not?
Yeah. Yeah,
Does this mean increases the amount of this drug in the blood?
Yes. Yeah. Increases the amount of the drug in the blood, which in turn could cause MNS and EPS symptoms, right? Yeah. So you're more likely to get toxic. So your book does say with the grapefruit juice, it does say that you can limit it to like 4 or 8 ounces a day. But I know that's still a good, healthy, yucky, gross cup of grapefruit juice. But I would just suggest Xing it out altogether. That's nasty, guys. Nasty. And then always with these meds, with the elderly, because they have a long half-life and their metabolism is slow anyway, it's gonna accumulate in their blood a lot faster. And these have a higher mortality risk rate in older adults with dementia. Okay, so some drugs similar to aripiprazole. Thank you. I'm just going to call on you guys to say it for me. Okay, so we have risperidone. I was the pharmacy. I can pronounce a lot of them. Ziprasidone. Geodon. A lot of these have generics out now, but when I was a pharmacy tech, they were all brands. So I knew like Abilify, Risperidone, Geodon. I think there's a Zyprexa in there somewhere. Anyway, and so I get these generic ones, and I'm not quite as fluent with them. So let's see what else I need to. Okay. So what, as a nurse, what are you, so say you're in a hospital, you're not necessarily teaching the patient, but what are you going to monitor and do? I know we kind of already touched on this, but.
I don't even have grapefruit in the hospital, right? You can get grapefruit.
No. Well, no.
We have grape juice.
There's grape juice.
That could be nursing. Orange juice, apple order, grapefruit.
Pineapple. No, I think there is grape. Cranberry. Cranberry's the other one. Okay. So what are you going to do as a nurse knowing that your patient's on these like antipsychotic medications? Check your blood sugars with the atypical. Right. Right. A psycho assessment, right? You're going to look at their, document their behavior.
Like their tremor stuff for the extra parietal or whatever.
Right. Watch for the EPS symptoms, right? With the tremors and the all that good stuff. No, not with these. They don't have peaks and troughs with these.
You're going to monitor drugs they brought from home in case they brought St. John's wort.
Right. A good medical history. Are you taking St. John's wort?
Yeah.
Or any other herbs, actually, because as we have learned, I don't know if you've caught on, but as you've learned through all of these presentations, a lot of them are unregulated. They're not tested.
They don't have a lot of doses.
They don't have very good dosing, right? Some of them, like Valerian, didn't really even know if you could overdose on it. You know, so, I mean, all of these things. And because they're plants that you can grow in your backyard, why would the pharmaceutical companies spend money studying these things when they can't really market it? Yeah, I mean, that's where they get their money back, right? Is marketing it and having people buy it. But if they're like, wait a second, this bottle of St. John's wort, it's $30. I can go plant it in my backyard.
Yeah.
You know what I mean? Because, I mean, we all know, like, to get drugs on the market, it takes years and years and years and tons of money and studies. And so they're not going to spend all that time doing something that they can't copyright. Is that how it is for product? Patent.
Yeah.
or they can't patent it, right? They're not gonna get any of that money back. Okay, so here in the slides, this is where we get into the anxiolytics, which we already covered. Now antidepressants. We're almost done, guys.
It's kind of ironic that the not just wait, never mind. Okay, not depressed is more bright, but that makes more sense.
Okay.
So you know last week you guys had like a document for the unit that had everything like in sections. Who did that?
That was from previous semesters.
They did that?
Mm-hmm.
Oh, it's wonderful. This is the best grade I've gotten.
I thought
And
it
I
was gonna
studied
be like
mostly
the
that.
norm. I only studied for an hour and I got an 83 because of that.
So I don't know if you guys can take that format and write information down from every unit.
But then it takes time. It takes time away from studying for me. I just want it there for me to study and then I can do fantastic things.
You do. You have it there for you to study.
The last two chapters I haven't read the book at all.
And to each their own. I mean, I know people who are like, who've come to me and said, I've started reading the book and I'm doing better. So like I said at the very beginning, everybody has different learning styles. And whether it's looking at videos and watching them versus reading a book versus writing your own notes versus listening to me, that's why I try to have a whole lot of different ways. I have it written out, plus I have the pictures, plus I have a video, you know what I mean? So I try to, yeah.
We need hands on. But so do you have any more of those for any of the other units from the previous semesters? Curious?
I might.
Okay.
I might.
So
I don't have them for all of them.
did you guys make them or are you saying the student made them?
So from my understanding, what happened was they did it like in a Google document that was shared, and they had the format, like, the drug with the nursing considerations, and then all the students went in and actually filled it out. So it was like a whole class contribution.
Oh, I'm not willing to do.
So we can do that. I can.
It was like exactly copied from the PowerPoint, though. Yeah. Anyway, well, it was good. I was wondering. It was.
So.
Very helpful. Be a homie. Yeah, I feel like we like bonded on a personal level today. So. You want to hook a girl up?
I'll see. And like I said, we don't have them for every unit. It's only like a kind of hit and miss. So I'll see what I've got.
I'm going to post them in the morning that you put the PowerPoint up and everything. You'll post it if you have them. Okay.
We'll see.
Thank you. Oh, we'll see. Tell my mom.
What, Megan?
I got like 40 minutes left until my brain explodes.
Okay, let's hurry. All right. Here we go. Depression. It's the second most common chronic clinical condition. Which one's the very first? Who knows?
Anxiety.
Nope.
Obesity. Bipolar.
Chronic clinical condition. So it's like anything. Hypertension. Hypertension's number 1. Depression's number 2. Contributing causes: genetics, social factors, environmental factors, biological conditions.
Diet.
Affects more women than men. Diet is also in there, yes. And then there's 3 types of depression. So here are the 8 most common causes. So there's your brain chemistry, genetics, biology, drugs, stress, nutrition, sex hormones, traumatic events, health problems. They all can cause. So the 3 types that your drug book talks about. There's reactive. It's a sudden onset. The patient knows why they're depressed. It's usually called the blues. Can last for months. What things would fall under this category? A death, failing pharmacology, death, anything that's like a traumatic experience, like maybe COVID. something like people know why they're depressed. Maybe the birth of a baby, the postmenopausal stuff, right?
But isn't that more of a hormone thing that it can still fall under that category?
It can be, yeah. Yeah. Okay, and then there's major depression. This is where it kind of goes further and you get a loss of interest in work and home. You can't complete tasks. You either have insomnia and you can't sleep, or maybe you're sleeping too much and you can't get out of bed. Okay, you have fatigue, you feel worthless, you get into some deep depression, dysphoria, and then you have kind of like with the anxiety, you have your primary and secondary unrelated to health problems, and then your secondary related to health problems. Good heck, it is getting cold in this room. You guys all seem to like it. Okay. And then we have the bipolar disorder, or a manic depression that it used to be called. That's where you're swinging between two moods. You have your manic and then you have your deep depression, right? Okay, common treatments for depression. This is kind of like the same with the anxiety. You've got your therapy, your personal psychotherapy, or maybe you need family and couples therapy, right? You can do hospitalization, self-help strategies, which include meditation, exercise, maybe the pet or music therapy, stuff like that, and then medications. Okay, yes.
I've heard that there might be a correlation between depression and altitude. Have you heard anything about that? Or I'm just sure there's really high rates of depression in Utah, and I think there might be a correlation.
What about Colorado, though?
Well, they got weed over there. They don't count.
Touche. They've got weed. They've got that figured out. Yeah, I don't know. I haven't heard that, but I don't know. That'd be interesting to see if there's a correlation between altitude and depression. Okay, so different types of drugs to treat depression. We've got the tricyclics, selective serotonin, norepinephrine, all reuptake inhibitors. These are what their nickname things are, mnemonics, what they're called. There's your MAOIs, stands for monoamine oxidase inhibitors. Okay. All the 5 types that we're going to talk about. Okay, tricyclic antidepressants, they block the reuptake of norepinephrine and serotonin at the synapses in the brain. Okay. It's one of the 2 oldest antidepressants. So TCAs and MAOIs are the oldest types of antidepressants used to treat major depression. Effective and less. It is effective and it's less expensive than SSRIs, but because they're older, they have worse side effects. They block cholinergic and adrenergic alpha-1 and histamine receptors as well. Off-label use used for children with enuresis or nighttime bedwetting. Anyone have friends, family, their own children that had to take this? I thought I would need to. Not me personally. My son. I just did a Kim right there. I thought my son might need this, but he got over it. It took till he was like 12, but he got over it. But it can cause blood dyscrasias. So it requires close monitoring of your CBC values. And it should be given at night to minimize daytime sedation. So why do you think it helps to treat enuresis?
Because of the cholinergic receptors. Blocks the cholinergic.
Right?
I say block, but it's cholinergic.
It has some anticholinergic things which would cause urinary retention. There you go, your anticholinergic effects. Causes sedation, can cause orthostatic hypotension. So what's maybe some
and get them up slowly with help.
Right. Get them up slowly. So risk for falls is huge for all of these, right? All of the medications we've talked about all today, risk for falls. Except for stimulants, I guess. Okay, so you guys can read through that. All right. Those are TCAs. Pretty quick, right? Now we have our SSRIs. They block the reuptake of serotonin. I know, I'm sorry. Okay, used to treat major depressive disorders. Does not block the uptake of dopamine or norepi. Because because we're going to talk about SNRIs, which block the norepi. So this does not block the norepi, just the serotonin. Okay. Fewer side effects than TCAs. Also used for these other things. And then these are the meds that go with it. So we've got Celexa, Zoloft, Paxil, fluvoxazine, Prozac, good grief, Luvox, and Lexapro. Any of you have heard any of those? Okay. These ones also, all of these some more than others, but all of the antidepressants are going to cause some kind of sexual dysfunction. Whether it's a decrease in desire or up to erectile dysfunction where you're having performance problems, lack of reaching orgasm, stuff like that. So they vary, but they all will cause some kind of sexual dysfunction, which can be a problem with couples sometimes. I've had friends where I had one. They would probably change to a different one to see if it. So I had a friend who was taking Paxil, and then you entered nursing school. Now they're all gone. She was taking Paxil, and it was really affecting their relationship with her and her boyfriend. So she had to switch to Prozac, and it seemed to work better. I don't know. I really didn't get into it, but I know they had problems when she was on Paxil. Okay, SNRI. So this blocks the reuptake of serotonin and norepinephrine. Okay. Increases the availability if they're not getting reuptaked. There's more there. Okay. This is the first drug class to be approved by the FDA for dual treatment purposes. So it's also an antidepressant, and it can help chronic neuropathic pain or fibromyalgia. Not important to know. It might be important to know.
Well, no, our slide's messed up.
Oh.
That's not important to know.
So that might be good to know that these SNRIs can also treat neuro pain. And then there's other approved uses for different anxiety disorders. This is where you get your Effexor and something else I can't quite remember. Venlafaxine is Effexor. Okay, here you go. Yes.
I know there's Effexor and Effexor XR. What are the benefits or cons of taking one versus the other? No, one's extended.
Yeah, so one's an extended release. Sometimes you can take Effexor twice a day, but then you take the XR and it's just a once a day thing. You're going to get a higher level of medication longer with the XR versus this thing you're going to get like this. Does that make sense? So look, more anticholinergic stuff. With all of these, well, with the serotonin ones, you can get serotonin syndrome. So watch out for that. Now, a lot of these antidepressants, you can get people who maybe one of the, what am I trying to say? I think it's a black box warning on some of these, that taking these for antidepressant can actually cause suicidal ideations, right? So why do you think that is?
I just make them like more less concerned. They're not so. Isn't something like that like they are more activated about things and do it? But
So my understanding with a lot of these is because when you're depressed, you have the fatigue, you have the sleepiness, you have all that stuff. You're taking this and it actually gives you energy. So now you have the energy to go through with it. So one thing when patients are on these medications, especially when they start, and it's kind of a new medication, they've already had suicidal ideations, you need to tell the patient and the family, like make them aware of this, that it can actually make it worse. And so that's why treatment for depression is kind of not necessarily one thing works. Like you take the medicine, you do counseling, you have, there's combination of treatments that can help. There's a video about serotonin syndrome, which I'm afraid won't work. I'll get it. I'll post all these up, I promise. And you can go through and see those. Okay. MAOIs. What do we know about MAOIs? Okay. Why is that?
that word. She got it.
Tyramine, okay. Because those enzymes help break it down in your GI system, right? If we're inhibiting that, then we can't break it down, and then it goes up into toxic levels, right? Also, Jenny, what did you say? Contraindicated in a lot of meds. So this is a lot like St. John's wort. And we've already seen a lot of MAOIs being contraindicated in a lot of the meds we've already talked about, right? So these are what MAOIs are now. So these monoamine oxidases inactivates the dopamine, norepi, and the serotonin in the brain. Now, if we're inhibiting those MAOs that inactivate dopamine, we're increasing the amount of dopamine, norepi, and serotonin in the brain. Okay? We're also inhibiting the metabolism of tyramine, which can be a bad thing. Okay, so MAOIs, they're non-selective because we have MAOAs and MAOBs. They don't care which one they affect. It's irreversibly bound. Okay. What else? We already talked about that. Hypertensive crisis. When we have too much tyramine. Is a hypertensive crisis like bad? It's life-threatening. That's right. Right. So we want to make sure that the certain foods and beverages that they know not to eat and drink, right? Okay, here's our selegiline. Black box warning of a hypertensive crisis. Now this also could be used to treat Parkinsonism. Not usually, just because we have those newer ones, the carbidopa, levodopa ones, that are much better. But you can do this. Here's a list of fun things that you can't eat while you're on these. If a hypertensive crisis is an adverse effect, you want to be careful with people with already hypertension. Okay. So nursing indications or teaching. Okay. Don't eat those things. Keep an eye on your blood pressure. Get up slowly. Anything else? Nothing else? Nothing else. Okay. All right, now mood stabilizers. This is the end of it. All right, this is for bipolar disorder, also known as manic depression. It has a really high suicide risk, has a high suicide rate. Those with bipolar disorder. Majority of these people stop taking their meds. Why do they stop taking their meds? Because they feel better. They don't need the medication anymore. They feel fine. Yes.
So sorry, just a random side note, but BPD is also borderline personality disorder. So how do you differentiate if you just see BPD?
Are you talking about like as on the test or just
Just in
anywhere?
general, yeah, if on the test in general.
On the test, I'll have it spelled out. I won't. If I have like these BPDs, I'll have it like, or if I do SSRIs, it should be all spelled out, like serotonin, selective serotonin reuptake inhibitors. As far as like in a like a patient's chart or something, that's a good question. Maybe ask the doctor. Yeah, so they stop taking their meds because they feel better. They don't feel like they need the meds anymore because they're healed. And then they go down the slippery slope again. We don't know why this happens. No cure, but there is treatment. Okay, they have similar symptoms to people with drug abuse, severe anxiety disorders, schizophrenia, dementia, and then even electrolyte disturbances. People connect funny with those. So these are the drugs that help treat that. What about valproic acid and Devoprox? What are those also used to treat? Anyone online know? I think they're all sleeping. They're done. Seizures. Yep. So we're just going to talk about two of them today, lithium and valproic acid. Valproic acid is not on your list of drugs, but you'll want to put it on there. So lithium is a prototype drug. It was the first drug used to manage bipolar. It is still used. However, as we'll see, the valproic acid is becoming more popular. Controls hyperactivity and flights of ideas. It reduces suicide risk. And then when somebody stops taking lithium, the manic behavior returns. So that's kind of where we get the trouble controlling it, because they'll stop taking their medicine because they feel better, and then all their symptoms return. There are a few off-label uses for lithium. However, it has a very narrow therapeutic window. This is one drug that you do test the levels on quite frequently. So when somebody started on this lithium, you're going to get blood tests 2 to 3 times a week, because therapeutic window is narrow. Toxic levels, it doesn't take much to get into toxic levels, and you're going to want to watch it really, really closely. I don't know exactly how it works. Maybe it helps with serotonin. I don't know. It works. Let's see what other things worth noting. Oh, never take it with NSAIDs. No CNS stimulants. And it is also, it can be up there with MAOIs and St. John's wort. There's a lot of drug interactions with this one too. Okay. A lot of ways. It can deplete your sodium. So you want to be careful. You want to watch their diet, make sure they're getting enough sodium. Check their electrolyte balances often because it can deplete their sodium. Right there. Sodium depletion. All right, nursing guidelines. So it takes about 1 to 3 weeks, has a narrow therapeutic window. It has a short half-life, so these patients are taking it multiple times a day. It can, toxicity is can happen semi-easily. So we want to follow up for lab draws, assess for signs and symptoms of hyponatremia, which are, 2 of them are listed. Muscle weakness and cramps, dizziness, lethargy. Evaluate diet routines for the sodium content. Make sure they're having enough sodium in. Be careful with excessive sweating because that depletes sodium too, right? Make sure they have proper fluid intake, and then be careful of their intake of alcohol and caffeine. And then they'll want to report any significant weight loss or gain. Okay, and then the other med given for bipolar, which is getting more popular, is valproic acid, and it is an anti-seizure drug. Right? We covered that. It is FDA approved for mood stabilization, so it's not even an off-label use. It's replaced lithium. Why do you think it's replaced lithium? Less side effects. Keep reading the slide, it'll tell you. Has a higher therapeutic index, which means it has a wider therapeutic window range, right? So we're not, you can test your valproic acid levels, but it's not something like with lithium, you're not going to be testing it 2 to 3 times a week. This might be maybe every other week for like the first little bit. More rapid onset of action, so you're going to see results sooner. But it does not prevent suicide risks compared to lithium. And I don't know the reason for that. Kind of interesting to note, though. And that's all I got. Questions?
I hope you were recording because about 10 minutes ago.
Please record that.
Re-listen.
It's recording, guys. It's recording. Now
I was listening up until about 15 minutes ago and I just couldn't anymore.
That's fine. So I have a Kahoots for a learning activity. Get the blood going a little bit. It's going to be fun. Yes, go pee.
Hey, Corbin, just while you're getting pulled up, I have a question. I think you already talked about this, but going back, so lorazepam is dual classed and it's just based on the dosing of like what they're using it for. Is that correct?
Yeah, so we talked about lorazepam twice, right? One is a hypnotic and one is a sedative, or one is a sedative hypnotic and the other one for anxiety, right?
Yeah.
Yeah, so it's still the benzodiazepine, so same class, but yeah, it can be used as both.
And is it like more common to have lower doses will be used as an anxiety and then higher doses are used as a hypnotic, or does it not really matter?
No, so yeah, that is dose dependent. So yeah, you'll want to use less dosage for the anxiety control and then a higher dose for the hypnotic sleep aid.
Okay.
Yep.
Thanks.
Why can't I pull this up?
Did you know?
You know Cooper Hazen? She's a girl.
Sure do.
You know,
I did soccer with my husband.
who's your husband? So I grew up playing soccer.
Oh, you did? Did you guys
Loroca? Oh, okay.
I played for Loroca for a hot minute.
Oh, really?
Yep. I ran for my life.
Wahaha, there it is. Okay, and I'll tell you guys, and I'll say it again, but, oh, for the love. I have a cool pill squishy again available for the winner.
Are we so close? Y'all are just bitter at that point.
You are so close. Yeah, I'm gonna share the link here. Let me find it. That one? Nope. That's not it. Hold on, I almost got it. Here we go. Is there a way I can, oh, yep, there is. We do disco music. Hear the disco music.
How's it going, Dave? All right.
Oh, do we have to use our name?
Nope.
Okay.
Nope.
Not good. Not too bad right here.
Yeah, I can go back and we can stop recording.